That's the reason I give it up.
Introductions by members. Madam Clerk.
Introduction of bills. Orders of the day.
Government House Leader.
Thank you very much, Honourable Chair. In the main chamber, I call Committee of Supply for the Ministry of Health. In the Douglas Fir Room, I call Committee Room, I call Committee of the Whole for Bill 19, the Child and Family Development Statutes Amendment Act. And in the Birch Committee Room, I call Committee of Supply for the Ministry of Education and Childcare, followed by the Ministry of Post-Secondary Education and Future Skills.
Committee chairs.
Call the Committee of Supply to order. We're dealing with the Ministry of Health's estimates, and I recognize the Minister of Health.
Thank you very much, Honourable Chair. I move vote number 32 resolved that a sum not exceeding $13,710,062,000 be granted to His Majesty to defray the expenses of Ministry of Health, Ministry Operations to 31st March 2025. Thank you.
Recognizing the member for Prince George Valemount.
Thank you very much, Madam Chair. Good afternoon to the Minister, staff, and the Chair. I know that we are literally on the clock now, and we have, just as the Minister has binders of answers, I have binders of questions. So I'm hopeful that we can work through them as expeditiously as possible. In some cases, I may just read the question into the record, and the Minister I would be very happy if he'd provide a response at some point in the future. But I would like to begin by ceding the floor to my colleague from Kamloops, South Thompson, so that he can ask his questions, and I'm sure the Minister will have all the answers that, that my colleague requires.
Recognizing the member for Kamloops, South Thompson.
Thank you very much, Chair, and thank you to my colleague from Prince George Valemount. And I see the Minister has a great big smile on his face, so that's good. You and I reunited once again, yeah. Anyway, so I'd like to ask a few questions about the Cancer Centre in Kamloops. And I will preface this by saying, I mean, there's been a lot of back and forth on this over the years. I'm going to spare everyone sort of the historical sort of assessment of how we are where we are today. I think what really matters is, with a business plan having been approved recently on February the 8th, and work underway as we chart a path forward where there will be a cancer centre in Kamloops. It's on the horizon. I think the critical component now is making sure that we get the cancer center right, and that the components that are part of this facility actually truly make sense, based on the input and the feedback of the healthcare professionals that are currently delivering cancer services in Kamloops. So I just have a series of questions. I'll try to be as brief as I can in posing them, and would hope that the minister can be concise as well in his responses. So the first off, the current Kamloops Centre facility is, as the minister knows well, is considered a community oncology network site, so a CON site, and it's under Interior Health Administration, although physicians are paid by PHSA. Regional BC cancer sites are under PHSA administration. Now, the new Kamloops Cancer Centre recently announced consists of a four-floor parking lot. There's a floor for radiation services. This new site, as I understand it, will be under PHSA administration, while the systemic side of cancer treatment, so the existing CON site, which is existing in Royal Inland Hospital today, will remain under IHA administration. This fragmented cancer care in our community, as represented by putting the medical oncology and the radiation oncology in two separate geographic and administrative silos. My understanding is that this type of model is unproven, and that there's no other small cancer center in Canada or the United States that have the medical oncology and the radiation oncology siloed in two different buildings. I'm also told that this plan was announced without engagement of the local Kamloops cancer healthcare providers, and I'm certainly hearing from a lot of them who are quite concerned. So I guess the first question would be this: could the minister specifically point to where in North America this model of a fragmented delivery of cancer care between the systemic on the one side and the oncology on the other, where in North America this exists, that the minister or the ministry is basing the plan for the Kamloops Cancer Centre, and why would the minister think that it's a good idea to proceed with this unproven sort of fragmented model that certainly wasn't advanced, and it doesn't appear to be supported by a good number of the healthcare professionals who are delivering the cancer services in the existing community cancer clinic in Royal Inland Hospital today?
Minister.
So the answer starts in 2002, but I won't do that, except to say that this plan and this way that we govern cancer in BC comes out of the reorganization, the creation of health authorities in BC in 2002 by the previous government. And so what happened was, and I know that predates the member's time in the legislature, but by a little bit, although I think he was here. But in any event, he was in town. But what we have is a cancer center that's run both by the PHSA and by regional health authorities. BC Cancer for the PHSA and regional health authorities. That's the structure that's been in place since that time. And there has been some comment about that over time, but the system is quite integrated. But what we are doing, and it's envisioned in our 10-year cancer plan, is to provide further integration in that, We're going to be engaging with oncologists in Kamloops and other communities about this as well, particularly in interior health. It's the decisions that were made at that time to have a province-wide system, but a lot of what is cancer care is also provided by regional health authorities. So this is a made in BC system that stems from that time. We are looking at greater integration, including in Kamloops, but it's consistent with what's happened in the management of cancer care over a long period of time. I just wanted to introduce directly behind me Dr. Kim Chi, who's the leader of BC Cancer in BC.
Member.
Thank you, Chair. I think the piece to be really clear on is that the regional cancer centers, so if we talk about Kelowna, we talk about the center in Prince George, we talk about the center in Victoria. I mean, these are fully integrated cancer centers that have both the oncology and the medical sides done, or the radiation sides done in the same facility. Or they're fully integrated. And I think the concern that is being expressed in Kamloops is that that isn't the plan going forward with the investment being made. Often radiation is given concurrently with chemotherapy, so the medical and the radiation oncologists have to work very closely together. I'm just expressing the concern that local healthcare professionals have brought forward. The question that they've asked me to ask you is, how will this integration actually work? How can we confidently say it's going to work as best as possible when the two different sides of cancer care are working in two different geographic locations, very much siloed under the administration on the one hand by PHSA in terms of the radiation side, and Interior Health continuing to administer the local side. How are they going to be possible? How can they best integrate their services when they're in those two different locations? They're under two different administrations, and even furthermore, they're using two different electronic medical record systems.
Minister.
Thank you. By working together, and that's the absolute intention to do so, not just in Kamloops, but across the province. There's a lot of aspects of cancer care, including surgery, that are inevitably and will be continued to be done at the health authority level. A lot of support for patients that's done, but further integration is required. And what we're going to do in Kamloops is what we'll do in other places, which is work with the oncologists, working in some ways in both streams, and the staff working in both streams to ensure that that integration occurs and that work occurs. And that work starts really now, because even though, as the member will know, the business plan's approved and we're going forward with the request for proposal soon, and then going on with building the center, a huge part of the preparation for that will be the recruitment of staff and working together to ensure that this center is all that all of us who believe in a Kamloops Cancer Center want it to be. Member.
Thank you, Chair. And I do appreciate the Minister's comment about working towards further integration in the future. I guess the frustration and the concerns that are being expressed by the local the healthcare providers in Kamloops that are delivering cancer care today are saying it would be better within the context of a significant investment being made for that integration to have been a feature of the new cancer center, and that it actually truly be a regional cancer center in every way, shape, and form, as is the case in Kelowna and Prince George and Victoria and elsewhere. That's the concern. I'll move on to my next question, though, and this is all tied together. If concurrent chemoradiation is provided, I think we all acknowledge that there will be a corresponding increase in patient care volume. The current team of health professionals delivering cancer care in the community have been, I think, making tremendous efforts, but nonetheless have been trying to recruit medical oncologists and general practitioners in oncology to the Kamloops Cancer Clinic for years without a lot of success. When you compare the existing systemic, the con center that's in Kamloops, when you compare the con center physicians to regional center physicians, the con physicians see more patients. So these are, again, the physicians that are in the existing cancer clinic in Royal Inland. They see more patients. They have less protected time. They manage typically more tumor sites. They have less support, and they're offered and they're not offered paid sabbaticals like the regional cancer center physicians. They are paid the same annual salary as regional center physicians. Hence, all new recruits have to this point have chosen, when given the option, new recruits have chosen to actually go and work in a regional cancer center where they have all of these additional supports, and they're choosing not to go to the con centers like the clinic in Kamloops. So the question would be this: could the minister just outline how Interior Health, the PHSA, the Ministry of Health, how do you envision the Kamloops Medical Oncology team will deal with this expected increased volume of patient care, concurrent chemo radiation, when the existing Kamloops Cancer Clinic is already massively overstretched and having significant challenges at recruitment?
Minister.
So thank you very much, and to say that Dr. Chi has already begun that consultation with respect to the member's first two questions, and we expect that work to be happening this summer. Understanding that the new cancer center will be in place later on, and I know the member wasn't suggesting we should delay the cancer center in order for that to happen. So I'll leave that aside. We, as the member can imagine. My desire is to go on these projects, but part of going is ensuring that we recruit. We're going to have an occasion, I'm sure, with the opposition health critic to talk about cancer recruitment, just to say, since the cancer plan came into place, 94 new cancer doctors working for BC Cancer across BC, and that involved a change, in that case, in recruitment and in payment. So our base rate for oncologists went from $410,000 to $472,000, making us competitive with everyone else. And what we found was doctors came back because it was not because of the money, but because of the recognition that indicated. Equally, we've done the same with RTs on the radiation side, and that's been an important, and we've made very significant progress there. So this has been the best year net that BC Cancer has ever had in terms of recruiting, and we will have a major recruitment plan, including in hard-to-serve areas. You understand, I think there's 42 community oncology network sites. We're also looking at HHR issues and at payment issues there in order to ensure recruitment everywhere. As the House will know, because we've talked about this before, we're going to go from in the neighborhood of 34,000 diagnoses this year on a population increase of 575,000 over 3 years, which is stunning in BC. Just think of the share of that share of population that is cancer. And so we're going to go from about 34,000, we expect this year, new diagnoses of cancer, which is way up to about 45,000 in 10 years. So what is required in Kamloops is required everywhere. And one of the areas that we're really focused on in the plan is also the community oncology network sites. These new regional centers are going to be important, and IMO and Kamloops and Surrey and Burnaby. There'll be major recruitment efforts there, but we also have to support the community oncology network sites. I hesitate to use the acronym, the community oncology network sites in 42 communities, which are vitally important. I've visited them everywhere, including in places as diverse as Vanderhoof and Trail around the province. Those are important sites. We have to continue to be able to recruit to those sites. And we're looking specifically at that now, because what you don't want and what we don't want is the new cancer centers in Kamloops and in Nanaimo to affect our community oncology network as well. So that work's being done, and in hard to recruit areas, we've been looking at significant supports for people. So I think that sort of addresses that question. I think people are going to want to work in Kamloops. I think it's going to be exceptional. I think the team is going to be able to define, working together with BC Cancer, the care that's provided. We're certainly open to all of the suggestions to make sure it's as seamless for patients as possible. We have, we'll know cancer patients in my family. They've gone through both the radiation and chemotherapy recently. So we know, like on a personal basis, and then collectively, all of us have constituents and others who've been dealing with that and know that you're in one system, you want to be treated as if it's seamless. And these questions that develop, there'll be questions for the organization, but not for patients.
Member.
Thank you, Chair. Yeah, I mean, I completely agree in the sense that I think we're, the minister and certainly I would suggest every member of this House would support the most seamless and integrated care that we possibly can. And we know the prevalence of cancer is increasing, the rates are going up, the people are living longer, there's just more overall sheer volume of cases. We know that that it projected in Kamloops, the chemotherapy treatments are projected to increase significantly. So this again all boils back to making sure that that the healthcare professionals that deliver the cancer care in Kamloops today have I think a better, a more confident sense that the building blocks that need to be there in order to successfully deliver on the promise of the seamless cancer care, that can actually happen, that will actually happen. And the concern around Interior Health continuing to administer the community oncology site in Kamloops versus PHSA managing the radiation side, the recruitment challenges that the community, the existing clinic has faced, and recognizing that unless the minister can correct me if I'm wrong, it doesn't appear that the community oncology site is going to disappear anytime. The challenges around the existing site from a recruitment perspective, which I mentioned in my previous answer, from a staffing perspective, is that the physicians, that there are benefits and entitlements and things that the physicians have in a regional cancer center that they don't get with the community center like the one we have currently in Kamloops. I said that the community center physicians are expected to see more patients. They have less protected time. They manage more tumor sites. They have less support. They're not offered paid sabbaticals. These are all factors that come into play in a deeply, deeply competitive labor market where we need a heck of a lot more cancer professionals across the whole board in communities right across the whole province. And there is a perceived, hopefully not real, but at least a perceived disadvantage being baked into the cancer plan in Kamloops by having IHA manage the one side that doesn't offer the same realities that are as attractive to recruitment and hiring physicians as there is on the regional center side. And it simply boils down to, if this is truly a regional center, a regional cancer center that's intended, then why isn't this integration just part of the, it's just a feature of what Kamloopsians and the region can expect when this new cancer center opens its doors on day one. And another aspect to this is, which again, this just further underpins the frustration and the concern and the worry that a lot of the healthcare professionals delivering cancer care in Kamloops today have, is this. When the government announced its new 10-year cancer plan with $500 million to improve cancer care, part of that was to hire 400 plus additional cancer professionals across the province. And I again stand corrected if the minister has a different number, but I think around 300 were already had already been hired. But the point is that none of those hires were directed towards these community cancer sites, like the existing clinic in Kamloops, like none of them. That's against the backdrop of estimates that the con sites, like the cancer clinic in Kamloops, provides 50 to 70% of all chemotherapy treatments. Yet, because they're under IHA administration, they don't receive any of the additional supports that have been rolled out to the regional cancer centers. And those additional supports really matter. So there's everything I've talked about from a recruitment perspective that make things more attractive to the doctors or to the physicians. But these other supports include things like having a dedicated cancer pharmacy. I do appreciate that the existing cancer clinic in Kamloops is being relocated to the main floor, so it's adjacent to the pharmacy. That, I'm told by the healthcare professionals in Kamloops, is not good enough. And that the Kamloops Cancer Centre, at the end of the day, will be the only so-called regional cancer center that doesn't have its own dedicated cancer pharmacy. So that's number one. There is a whole bunch of support services that aren't included in the plan, such as counseling, psychiatry, a drug navigator, clinical trial navigator, administration support, adequate nursing levels. These are all the concerns that are being expressed to me from these healthcare professionals, again, that deliver cancer care today in the existing Kamloops clinic. So when you look at the differential from a recruitment perspective, the differential that there is that make things more attractive for physicians to go to a regional center versus a community cancer clinic, and you look at the types of additional supports that are just inherent with a regional cancer center or anywhere else that they exist in the province, but won't be in place in Kamloops, certainly not when the new cancer center opens up and the existing cancer clinic is relocated. I guess the question that healthcare professionals would want me to ask the minister would be, how can the minister and this government refer to this cancer project as a regional cancer center? And the minister did refer to the Kamloops Cancer Center that's planned as a regional, it will be a regional center. How can he refer to it as that when it won't have many of these features and components that exist at all the other regional cancer centers? Again, a dedicated cancer pharmacy, support services like counseling, psychiatry, drug navigator, clinical trial navigator, and so forth. None of those features will be included in the delivery of cancer services in Kamloops, even after this project is completed.
Minister.
So with respect to the community oncology networks, just to be clear, we're moving from 6 to 10 regional cancer centers, which is great news for people. But we also have 42 community oncology network sites. and we are on the human resources issues on those sites. I know the situation in Kamloops and in Nanaimo is different because they're both moving to the regional cancer centers in those places. But we have a regular working group on the con sites that's going to see these things, and will require improvements be made because the increase in demand for chemotherapy in community around the province is significant. And so that's the work that's taking place now. With respect to the Kamloops Cancer Center, the work is starting. And so, and we will be doing that work as we always do with the health professionals in community. With respect to pharmacy, and just to talk about the proposal for a little bit, you're going to see significant renovation. And really what it means for the pharmacy in Kamloops is that the cancer pharmacy will be co-located with the rest of the pharmacy, which is not, I think the member would agree, necessarily in itself a bad thing. Right? And certainly significant renovations and relocation are going to happen to the existing con clinic, to the existing pharmacy, and to make sure that, and we're going to see a significant expansion of both. And I know the member knows this, we won't talk about parking because he's asking really specific questions about cancer, but that's added too. So this is going to be a phenomenal regional cancer center. It's going to be phenomenal because of the people who work there now and the people who are going to recruit. The work is happening now to make sure that for patients, this is a regional cancer center and all of these issues are just something that happen between health professionals. But I expect it to be just a spectacular success because I know the people there and I know the member has met with some of the people there. And that work is happening and starting, some of that work is starting now. And we're confident that this is going to be a regional cancer center that everyone's proud of. And in the meantime, of course, RFP and building the cancer center and all those things are going on. So we feel we're in good shape to do all that. And Dr. Chi and his team will be leading those efforts starting, I think, next month with local doctors, local oncologists, and you can assure them that they'll be very much part of the process. It'll become and is their center in every way, and you do that by working with people from the ground up, and we're going to be ready to go. It's going to be excellent, that work. But on the Community Oncology Network, just to be clear, that's a very significant part, and I just note this, we'll be having, again, this debate a little later. We did, in total, 11% more patients and follow-ups this year than last year, in 1 year. That's an exceptional performance by our health professionals in cancer. That's everywhere in BC. That's at our 42 sites around the province. And that gives you a sense. So if you've got an 11% increase in 1 year, the increase in the number of people needing cancer care and the response, the exceptional response of the system to that need. And that's got to continue, and that'll continue in Kamloops.
Member.
Thank you, Chair. The healthcare professionals that deliver cancer care in Kamloops definitely were excited about the prospect of enhancing the infrastructure in Kamloops and building it out, and the prospect of a truly regional cancer center in Kamloops. Again, in every way, shape, and form, the same as in Kelowna and Prince George, Victoria, and elsewhere, was something that definitely has the healthcare professionals excited, and the community as well. But I come back to my original point that these questions I'm asking today are coming directly from the doctors and the others that are delivering the cancer care in Royal Inland Hospital today at the community network, the oncology network, and they're very concerned, again, about the fragmentation. They're very concerned about that there doesn't appear to be a plan to ensure that there are no differences between, if I can call it the working environment of physicians that work in the regional center, which are superior in a number of ways that I've outlined in my previous question, versus doctors or physicians in the community oncology network side. And those those additional support services, which are specifically spelled out as features of the regional cancer centers in these other communities, Prince George, Kelowna, Victoria, are not part of the initial plan for Kamloops, which has everyone concerned. The one final piece that I'll just add to the mix, because I just really want to understand the plan moving forward. The current team of healthcare professionals that are delivering the best possible cancer care they can in Kamloops with the resources they have are telling me that their understanding is that the square footage of the upgraded cancer clinic is the same as the current space. I've been advised that Interior Health has actually not sat down with these healthcare professionals who currently work at the existing Kamloops Cancer Clinic to engage them more fully in the planning process, despite frequent requests to have an opportunity to provide their input. That said, if Interior Health did consult these healthcare professionals, they would be told that the upgraded space is inadequate, and in the opinion of these healthcare professionals would not actually improve or benefit their workflow or benefit patient care. And the reason being, and this is looking forward, right? The reason being, it was reported recently that the Kamloops Cancer Clinic saw 4,935 visits for chemotherapy in 2022. That's projected to increase to 7,187 chemotherapy treatments when the new cancer center opens. Those are numbers from Todd Mestel, the Executive Director of IHA Business Operations. So when in order to deliver that many more treatments, these healthcare professionals are saying more space, not the same, is going to be required, and yet that's not possible within the footprint of where the clinic is proposed to be moved in Royal Inland Hospital. So the question would be this, why is the minister proceeding with a plan that will not actually provide for the space and capacity needed to deliver what amounts to a projected 45% increase in chemotherapy treatments at the existing cancer clinic or community oncology network site in Kamloops?
Minister.
Just to be clear, in total, approximately 1,000 to 2,000 square meters of renovation, 19 to 20,000 square meters. Now, if it was square feet, it would be more, right? I'm looking to the my colleague from Williams Lake. 19 to 20,000 square meters of new construction is anticipated. 4,000 square meters of that new construction dedicated to the cancer center, and the rest making up the Park 8, which has the most square area, as the member would expect. And the overall project cost for the project is estimated, and obviously will be in an RFP process, is at $359.04 million. Just by way of comparison, the one in Nanaimo is $288.76 million. So this is, I think, a significant increase to both the size and the services delivered. But I think the point the member's making is that that there's a need to engage with local people in the community, and that's exactly what's going to happen, and exactly what you would expect to happen, to make sure that this really very significant investment in the hospital, and a hospital that between the previous government and our government has received very significant increases over time. So this is a building out. This is going to be, as a hospital site, a fantastic hospital site. And the cancer center is going to be integrated in that, and we're going to be preparing and working with those that are working there now, and those that we will be adding to that will be coming to work there in the next period. And we have to, at our community oncology networks, respond by both issues of space, but also in terms of issues of hours, not on one site, but at 42 sites. If you're seeing that kind of increase in diagnoses, expecting and you know, a very significant proportion of those will be chemotherapy. Some will require radiation, and some, of course, require both. And so, I think what the member is bringing to my attention is some concerns by local people who provide cancer care. I'm saying we'll hear those and engage those concerns. They'll be part of the process because this is their center. It's not my center, it's our center, and we want it to be successful. And that means doing the very work together that both I and he have been talking about.
Member.
Thank you, Chair. I do hope that the minister ensures that there is true engagement with the healthcare professionals that are delivering the cancer care in Kamloops today, because I can assure the minister that that is not how most of those healthcare professionals feel today. Many have indicated that they've written to the minister, haven't received responses. They've tried to engage the local reps that are involved in advancing this project and haven't been able to engage. And they, I think, are raising some very legitimate concerns. When I talked about the concern these healthcare professionals have around the square footage of the relocation of the community oncology network site, so the existing cancer clinic in Royal Inland Hospital, the local healthcare professionals delivering the cancer care in Kamloops say that their understanding is that footprint is not going to be any bigger. I completely understand that the actual new cancer building, the cancer center building that has been announced, has a floor for radiation services and some other pieces that are related to that. Obviously, that's all net new space. I get that. And I know there's 4 floors of parking. There's much needed parking at Royal Inland Hospital. So there I got it in for the minister so he didn't have to. But that's not to say that, that the concern that these healthcare professionals have expressed about how the heck they're supposed to deliver a 45% projected increase in chemotherapy treatments within the Con Clinic in the Royal Inland Hospital in the relocated space when it's all done, when that space is not any larger than the space that they're in today. That's the point. So I'm going to end here, and I'm very appreciative of the time that that my colleague from Prince George Valemount has provided for me, and the opportunity to have this back and forth with the minister. But I want to end on this note. One of these healthcare professionals delivering cancer care today, asked me to provide this quote to you from her on behalf of the department, and it goes as follows, and I quote. We owe it to the citizens of Kamloops and the entire region to ensure a sufficient cancer centre is built in our community, one that is endorsed by the current team of healthcare professionals delivering cancer care in the community, one that will encourage recruitment of cancer care physicians, and one that is sufficient to service our future community cancer needs. Unfortunately, the current plan is inadequate and will hinder rather than improve cancer care in our community. That's our concern, end quote. So the minister, I encourage the minister to please direct the appropriate interior health officials, particularly with respect to the community oncology network site, the existing cancer clinic, to, as soon as possible, reach out to these healthcare professionals. They want to be proud of the investments being made. They want to be proud of the new cancer center, but they also want this, they have some pretty unique and I think valuable and very pertinent insight into best practices in the delivery of cancer care, and they feel that the project is not on the right track in a number of respects, which we've canvassed in this exchange here today. So the minister could please reach out to them, provide me that assurance. I know that will go a long ways to hopefully, if it's not too early in the process, to maybe course correct on some of these things and incorporate their feedback into the planning. And let's make sure that we get this very important Kamloops Cancer Centre, regional cancer centre investment and build out in Kamloops and for the entire region. Let's make sure that we get it right.
Minister.
Thank you. First of all, there will be a meeting that involves BC Cancer, obviously the PHSA with BC Cancer, IHA, local community teams, and local doctors on May the 13th. And really, this is the work we're doing now. We've gone through this stage, and we've had discussions over the years. My job, in some ways, is to set this in motion, to find the resources, to deliver a cancer center, and it's our team's job to make sure that it's all that we need it to be. And the only point I'd make to the member, and I said this in all the responses, is on the community oncology network side. We got a lot of work to do everywhere, not just in Kamloops. And so what he's highlighting there is, I know he's focused on Kamloops, that's his constituency. What he's highlighting there is something that we got to do everywhere. We got to do it in Williams Lake, and we have to do it in Prince George, and we have to do it everywhere else, but also sites such as smaller sites such as Vanderhoof, where they have community oncology networks that are seeing similar growth and demand. But I'm really excited. I mean, I'm actually excited to have this exchange with the member about how we're going to make the cancer center we're all building together a great thing. I would describe that as progress. The business plan is progress, the moving ahead, the delivering the service, and the work we're going to do together, because we want it to, ultimately, it's the people of the region who are going to benefit, and we want them to be involved, and obviously the health professionals in the region. So I appreciate the questions, that the work is beginning. Meetings have already occurred, and further meetings will be set up starting on May 13th, and that's the work now that we're doing, which is making sure that this cancer center is everything we want it to be.
Recognizing the member for Caribou-Chilcotin.
Thank you, Chair. Thank you very much to the member from Prince George Valemont to ask a couple of questions, of which is very valuable time here today. I have a couple of questions that will lead to geriatric care, but I need the answer to a few before we get there. And the first one is, what is the amount of residents in Caribou-Chilcotin? What is the number that are without a doctor now? And I'm going to combine a couple of questions in there as well. There's a process that has our residents having to pay $145. There's a process that has our residents having to pay $145 to retrieve their records. And I want to understand that process a little bit. Lately, I've had a number of calls with respect to this, particularly from senior citizens who find it hard to believe that records that should belong to them already belong to someone else. But I do want to understand that process, and if the ministry or minister has contemplated any other solutions to that, particularly for low-income people and seniors. And maybe I'll leave it there for now.
Minister.
Thank you. What we're trying to do to solve this problem, because it's a problem that I think also, aside from the cost of it, brings about a little bit of bad feeling between health practitioners and patients when it happens. You know, these belong to me? There's the cost of storing records when, say, a health professional retires or moves or so on. So what our solution to that is the expansion of the health gateway so that people will have consistent and constant access to their records across platforms. So this is looking to resolve the fundamental problem of how to deal with health records that are held for people over long periods of time. So we're directly taking action to move on that. The member wanted some specific numbers from the Central Interior Rural Division in terms of the health gate. This is Health Match BC. So these are the people who have contacted us seeking a provider in the region, and the active people are 6,035 who are seeking that within the Central Interior Rural Division. And just so a member will know, 635 of those have been attached so far. We're starting to work through that because of the work that we've done that we discussed last week in estimates. Further, 635 are attached, 381 are pending, so they're in the process of attachment. And so that's a start. It's not all of them, and that leaves some people without. But it's also the progress we're making. There are also doctors taking patients in the area, and so there's the numbers there as well. So what that number tells you within that Central Interior Division is that approximately 6,000 people are actively in the Health Connect registry telling us they need a family doctor. Roughly 1,000 of those are either attached or pending, so that's the start. And we've got work to do there and everywhere else to respond to people who want a family doctor. It's obviously means that we have to bring more family doctors to the region as well, which we're working hard to do, and maybe that will be the subject of subsequent questions. So the response on health records is putting together a health gateway that gives people access, permanent access to their records. So this issue of what happens when records go isn't become an issue between patient and doctor or patient and nurse practitioner. On the one hand, that's his first question, and his second question was the numbers I gave him.
Member.
Thank you, Chair. Thank you for that information. I suspect that number that hovers around that 6,000 mark are for people that have actually enrolled and are trying. So there are there probably are many more. I would suspect. I certainly in our region, I've never seen Caribou Memorial Hospital closed, and we've had a number of closures in the South Caribou as well. So I would suggest that number is quite low. What I didn't hear, I heard about a potential gateway with respect to recovering records. It's my understanding that those records now, for someone like myself who does not have a doctor and wanted to retrieve those records, it would cost me around $145. It's seniors that have a challenge paying that fee, and I'm just wondering, has there been anything contemplated on that front to absorb some of that cost away from seniors?
Minister.
Interestingly, this was an issue I raised when I was health critic for the opposition in 2009, I think. So remember, might want to look back at those records, which we keep. But just to say what the portal will give people, gives people access to now, it's prescription record, lab result record, immunization history, BC cancer, cervical screening test results and recalls, special authority drug request status, hospital visits, healthcare visits billed to the MSP, organ donor registration status, diagnostic imaging reports. So that's what we're built out now, and we'll build out more of that. So I think the issue is to answer this question and change it, and to use the building out of Health Gateway to take this question out entirely. And I think, because I think it's been an issue for governments and for the health system for a long time. And I think the response is, if we're going to have a digital system, it has to work for people. It has to give them control and authority over their records. So that's the permanent solution that we're talking about. And talking about delivering with respect to the Health Connect registry, yes. But I would say this to the member, that what you see, if you see 1,000 people in the Central Interior Rural Division getting access to a provider. That tells you that we really want to encourage people to sign up as well, and that will deal with that number in between the number of people signed up and the number of people who don't have a family doctor, but it's also the best way to get involved. So I really encourage, I know the member's constituency office is active. We work with his constituency office in our office quite a bit, and so we want to encourage people to do that as well. I know that it doesn't necessarily mean there's a doctor or nurse practitioner or something there right away, but it is an opportunity for them. I think if you're looking for a family doctor and everyone on that list is, then that's the best way to do it, and really encourage people to join that. And right now we are, as the member will know, we have significant spaces that we'll be able to provide for people across the province. So I really encourage that part of it, which is separate and apart from the debate, the whole debate we're having.
Member.
Thank you, Chair. Thank you, Minister, as well. Just going to actual doctors now, Central Division has done, I think, pretty good work. They're very active, and they work hard to bring doctors, of course, to our community. But frankly, the last time they announced 5 doctors, I think the following day or certainly in the following week, 2 more had announced that they were leaving. So specifically to Caribou-Chilcotin, not referring to rural BC, I know that we hear numbers often from the minister that we've hired 700 doctors. I'm wondering what specifically is happening in Caribou-Chilcotin to bolster our supply of doctors, because honestly, as I said before, I've never seen Caribou Memorial closed, and I know that might have been for different reasons, but frankly, there is an unbelievable amount of pressure. And when I first started as MLA, I would say that it would be every week that we would get significant calls about this. But now it's a daily occurrence where people are coming into our office without doctors, can't navigate the system, et cetera, et cetera. So what specifically is the ministry doing to bolster that number in Caribou-Chilcotin?
Minister.
Okay, thank you very much, Honourable Speaker. So the core, of course, is something we put in place a number of years ago called the Central Interior, the Primary Care Network, that came out of the community. It was designed and directed by doctors and divisions of family practice and First Nations in the community. And so if you look at the PCN, the Primary Care Network, that's a total of, and this is hired between that and the All Nations Healing House, 53.9 FTEs, right, to support that. And that at its core is what we've been doing. That includes physicians, nurse practitioners, nurses, allied health professionals, pharmacists, administrative support like medical office assistants, which do an excellent job, and Indigenous resources as well. That just gives a sense of the support that's in place through primary care. So that's a start. And I just wanted to report on that. We can provide more on that and the details on that because we have regular reports on that. We have, as the member noted, 5 new physicians coming to Williams Lake this year through the Practice Ready Assessment and the EBC Internationally Trained Medical Graduate Return of Service. So when we have a choice in those programs where we're doing against return of service, Williams Lake's not just at the top of the list, it's at the top of the list in terms of the priority we have. We tripled the size. So last year we're tripling the size of the Practice Ready Assessment Program, which is very important, as you can see, for a community such as Williams Lake. Went from 32 to 41 now to 96 in that program. And that makes a very significant difference, not just to Williams Lake, but other parts of the member's constituency, another part of the Caribou-Chilcotin. Since January 2023, there have been 10 physicians hired to work at CMH, and 4 of them will join the family practice team with start dates between April and September. But as the member has noted, physicians have also left, right? And so that's a significant issue, and why, when we have any choice in the matter, we are assigning people to Williams Lake. And those programs, the PRA, the medically trained ones, those are where we have, against a return of service, an ability to place people. And the other reason we place people in Williams Lake is that our doctors and our nurse practitioners and our nurses in Williams Lake are just outstanding. I've met with them personally in Williams Lake. So that's a good place to have people establish their medical careers, and we've got to collectively do a better job to make sure that they maintain that status. We do a lot of issues around recruitment as well, and that involves Williams Lake as well. Relocation assistance, the BC Loan Forgiveness Program, all the work we've done with others, and it's obviously not just doctors, but the member asked about doctors, so I'll shorten my answer by talking about that. All the significant measures that we're putting in place. We just signed off on an APP for our hospitalists at Caribou Memorial, which is an important question. We signed off on that on April 10th, and that provides some supports. In addition to that, we're advancing virtual care, and our team was in Williams Lake, Interior Health team, I think the week of April the 8th, which is the week before last, working on that issue as well. So across the board, incentive, support, where we have a choice, Williams Lake is at the top of the list of priorities. And you can see that just as evidence. 41 this year, 3 to Williams Lake is an indication, SPC, of the priority that we give. And the work we're doing with hospitalists, the work we're doing in support, all of those are efforts to attract people to Williams Lake. And I believe we'll do that because we've got outstanding teams of medical professionals there. It's a good place for a practice-ready assessment doctor to go because they're going to get the support of outstanding teams of doctors.
Member.
Thank you very much, Chair. Thank you, Minister. I aim to help the ministry keep Caribou-Chilcotin on top of that list for sure. This is where I wanted to end up. The minister would be very aware of a situation that developed a few months back where we had a senior citizen that should have been in long-term care, but was in the hospital. And I'll thank the minister for helping us with that. But I was saddened to find out that there was not only one, there were a few people that were in the hospital. And here's the problem with that. One, there was an empty bed waiting for them at a long-term care facility. And 2, they were, of course, in a bed in the hospital, which we don't have a lot of beds, obviously. I want to understand that process and what is holding a resident from being transferred to the long-term care facility. Now, I understand that this only happens when a resident does not have a doctor, and so there's a need to have a 24-hour call or somebody available to receive a 24-hour call on behalf of that patient. But of course, if we're talking about 6,000 people without doctors in Caribou-Chilcotin, and we know that that number is much bigger than that, then we have a number of people that might find themselves in this particular situation. And of course, it's not a matter of capacity because there's an empty bed waiting for them. They've actually moved into an apartment, all their personal belongings are there, but they simply can't move over. Now, the problem becomes even more complex where we had 3 doctors taking care of geriatric patients in Williams Lake. 1 left, leaving 2. second one left, leaving one, and the final one said, look, I can't take this burden on, which I can absolutely appreciate the horrendous amount of work that would entail for that final doctor. Now, I understand that there was a temporary solution. I don't know the timeline on that solution, when that ends, but I do want to understand better how we could have one person that has an empty bed, that's in a bed in the hospital, and how this can be fixed.
Minister.
Honourable Chair, I'll have the answer to that in a minute. I have to move that the House rise, report progress, and ask leave to sit again. We just have a report to come in, and then I'll get to the answer to the very important question from the member.
All right, the question is adjournment of the committee. Members in favor? Aye. Opposed? Carried. Thank you, members. We'll see you shortly. This committee is adjourned.
Committee Chair.
Thank you, Honourable Speaker. Committee on Ministry of Health reports progress and seeks leave to sit again.
When shall the committee sit again, Government House
Later
Leader?
today, Honourable Speaker.
So ordered. Committee Chair.
Mr. Speaker, Section 8 reports Bill 19 complete with amendment.
Members, sorry. Members, when shall the bill be considered as the reported, Government House Leader?
Honourable Speaker, at the next sitting of the House after today.
So ordered. Government House Leader.
Thank you, Honourable Speaker. In the committee, in the Douglas Fir room, I call Committee of the Whole Bill 15 Budget Measures Implementation Act.
Committee Chairs.
Oh, call this House. And in the main chamber, I call Continued Estimates for the Ministry of Health.
Thank you. Committee Chairs.
Minister of Health.
Thank you. I move vote number 34, resolved that a sum not exceeding $32,710,062,000 be granted to His Majesty to defray the expenses of Ministry of Health, Ministry Operations to 31st March 2025. And we were discussing transfers out of acute care to long-term care, and just want to express again, we've had this discussion with the member for Prince George Valemont. I want to express my appreciation to the member's office and the work that we often do on cases such as this, and appreciate that work and the working relationship we have. There's debates in the legislature, but also we're working together for, and his office is working for his constituents every day. With respect to the long-term care thing, there is an interim solution. Right now we have the team at the Doctors of BC, the local division of family practice, the Ministry of Health, working together to look at permanent solutions to the issues that have been raised. The LFP model, for example, is having long-term care added to it because of agreement on June 10th. The new model for paying doctors, that's important. In the interim, we've added nurse practitioners to the model to support patients in their transfer, and that's important in terms of the care provided at the long-term care homes in Williams Lake. So those are the interim solutions. We're working together right now to build a permanent solution. A big part of that will be the application of the LFP model to long-term care, which is one of the issues that the member for Prince George Valemont and I discussed last week. So those are key elements to do that. I would say that the general problem, and I refer member to a written response we provided about the details of alternate level of care patients, that the issue of patients being in a hospital bed and not being able to get into long-term care is not the main issue with respect to alternative level of care. It's access to long-term care beds, why we're building so many in BC, because we have a rising number of seniors. And so that issue that he describes, which was a real issue, isn't the main alternate level of care issue. But that said, changing the LFP model to include long-term care, specific work being done, including by the Doctors of BC and ourselves, on the situation directly in Williams Lake, interim support that's going to carry us through June of this year from nurse practitioners. Those are some of the solutions that have been put in place, and the advocacy of the member has been part of that process as well.
Member.
Thank you, Chair. I only have time for one more question, but I do want to confirm. So I understand that there's an interim solution till June, so I'll follow up a month or two down the road to find out what the solution of that problem is to be. But I also want to confirm that this is not a situation where there's no space. In the cases that we've written about, in those cases, they've actually had the available beds. So, and that's concerning, right? Because by way of being in the hospital, you know, the care is obviously different in the long-term care facility than in the hospital, and of course, families were advocating for that move to happen. So anyhow, I'm glad to understand that the ministry is working on this, because I really do think it's a very serious situation, and we definitely need to come up with a practical full-time solution to it. I do also, before I ask my question, I just want to thank all of the workers in this system in Caribou-Chilcotin and the ministry, because this is definitely priority one in Caribou-Chilcotin, and it's very concerning. And just to note that when a hospital closes in Williams Lake, we are 3 hours, you know, to another hospital. And for folks that are in other areas in the Caribou, Tatla, Anaheim Lake, they're 3-4 hours into Williams Lake, not to mention another 3 hours off to Prince George or Kamloops, noting that, of course, if they could potentially stop in Hunter Mile as well. My final question is about Tatla Lake. Tatla Lake is run by an incredible group, much like the rest of Caribou-Chilcotin. We have some of the best folks in the system, I'm sure of that. But in Tatla Lake, certainly Patrice Gordon, Dr. Rob, Nurse Ruth, who is an icon in Medicare, they have been advocating for an upgrade to that clinic, and it's been my understanding that it's been approved in the past. We really have to consider an upgrade there. The facility is old. They're doing the best they can with it, but they are really in need of some support there. And I'm just wondering if the minister could comment on what plans there may be for Tatla Lake. We have had community meetings in Tatla Lake where we've met with Interior Health, and we have tried to push this issue forward. For lack of a better term, it's really just a small double wide there with a couple of rooms with paper-thin walls. There's not a lot of privacy for patients. There's older equipment and such. So I'll leave it there for today, but I'd like to hear if there's anything being contemplated for what could be a very affordable fix in the scheme of Medicare in this province.
I see member for Boundaries Milkameen.
Thank you very much, Honourable Speaker. I seek leave to make an introduction.
Is leave granted? Please proceed.
Thank you. It's with pleasure. I see up here the school group. I'm always happy when the schools show up, especially in this case, and get to see a little bit of the more respectful back and forth dialogue that takes place in this House. So on behalf of the Minister for Mental Health and Addictions, who I'm sure would love to be here to welcome you, but is busy elsewhere, please welcome Ecole Glenbrook from New West. So welcome.
Member. Welcome, bienvenue, Mr. Minister.
Bonjour tout le monde. What I'll endeavor to do, and there's a couple of meetings I need to have in the next week or two with members of the opposition. The member for Shuswap is one. The member for Vancouver-Langara is a meeting. I have meetings with a couple of members of the opposition that I need to do once estimates are passed, and then we have a little more occasion to do that. What I'll endeavor to do with the honourable member is perhaps if we could get together on a Zoom meeting with people in Tatla Lake so I can become informed. We'll do that in the next couple of weeks. We'll arrange for that before the end of estimates so that meetings happen, because those issues are critically important. They're also important to just recruitment, and the issues are different in different communities. Member for Shuswap has issues that he's raised with me with the hospital there. The member for Vancouver-Langara was talking about community health centers, and so these are really useful meetings as well. But on Tatla Lake, I think we can probably find a time together just to sit down and with the folks in the community and talk about those issues for 30 minutes, just so I'm fully informed, and that involves the inevitable process of having notes prepared for me about what's happened and having the appropriate officials on the line, so we're not just talking at a political level, but talking with everyone else. If we could do that together, and I'd be happy to arrange that with a member, and we can just sit down in my office and Zoom in to people in Tatla Lake in the next 3 weeks.
Member for Carriwood-Chilcotin.
Thank you, Chair. I'm sure they'll be very happy to hear that. I think they have an annual general meeting tomorrow night, actually, so they will be excited to hear that news. And I will just say, again, speaking to rural healthcare, it's really important, because I think we forget just how far some of those communities are apart. And I mean, I was just in Anaheim Lake. They have a clinic there. They have amazing service with a crew that is willing to really go the distance, right? And we're seeing that, frankly, all over Carriwood-Chilcotin and all over rural British Columbia, where the staff are really filling gaps that honestly are not their fault, right? But I do appreciate the comment that you made about not just the willingness to meet, but the fact that this can help with retention. It can help with getting people into rural British Columbia when they have nice facilities, state-of-the-art facilities, and frankly, that's really important in a small community like Tatla Lake. So I'm sure that Tatla will enjoy meeting with us then in the next 3 weeks, and I won't wait for that call. We'll send an email right away.
Member for Prince George, Valemount.
Thank you very much, Honourable Chair. Thank you to the Minister and staff for responding to my colleagues. It's a big province, and when it comes to healthcare and many other things, it is not one size fits all. So we're now into the short snapper section of the estimates, despite the many hours we spent together, because I still have half a binder to get through in the next several hours. So I'm hoping the Minister will be succinct in his response. I will try to be succinct in my questions. So I'd like to move to pharmacare for a bit. I'd like to talk about the Med Access BC report. And I recently met with a group of representatives from Med Access BC. The Minister would know that that is a coalition of 35 patient groups. And they are extremely concerned about the fact that, and I can almost anticipate the Minister's answer, but I want to be on the record as sharing the concerns of the people that I met with, that We are currently in British Columbia, our pharmacare program actually covers fewer non-oncology medications than any of the other provincial drug plans in the country. And in fact, it continues to decline as new medications are available almost everywhere else in Canada. We are the chair of the Pan-Canadian Pharmaceutical Alliance, and it's fondly known as the PCPA. And that, you know, that organization or that group actually completes price negotiations via a letter of agreement. Yet, BC patients do not have equitable access to medications. Can the minister explain to me why patients in British Columbia have to do not have access to medications that the vast majority of other Canadians do?
Minister.
Thank you, Honourable Chair. First of all, with respect to pharmacare, this is an issue of considerable interest to me personally. It's why we've made very significant improvements in our coverage, especially for lower-income seniors and lower-income people in BC, since I became Minister of Health on the in our pharmacare program in BC. So what happens when a drug is open, a new drug is open for review in BC, and this is an area where there has been consistency as between governments. So the model that I'm referring to was put in place in part by the NDP government in the 1990s, but significantly added to by the government of which the member was a part. And so we have a process where Health Canada will approve a drug essentially against a placebo. Their approval doesn't mean a lot in terms of its coverage decision. There's a review by an organization called CADITH, then a review in BC by the Drug Benefit Council, which is assesses issues of efficacy against costs and efficacy in general. And so the Drug Benefit Council does that work. That was put in place by the previous government. And only one drug, to my knowledge, and I think that knowledge is fairly complete, I think it was D-Dopa, which is a multiple sclerosis drug, was approved against the advice of the Drug Benefit Council in BC. And so consistent really with the situation we have now in terms of approval. Minister Lake did that, but that was a drug, multiple sclerosis drug, which had been not approved against cost in 2008, had been approved in other jurisdictions, and the company essentially didn't reapply to have it dealt with here. So the government acted. That was one example. It's an example that I supported at the time by Minister Lake when he was Minister of Health. So that's the system we have in place, which is, and there is, I think, in general, people will focus on the differences, but a high degree of consistency between provinces. After the approval by the council in that process, we go through the PCPA, which is a price negotiation process. And what BC has done over the last number of years, when people talk about money involved through the time of the previous government and then added to during my time, is also getting the best possible deal in BC, and that included the very significant biosimilars initiative, which perhaps the member will ask about. So between January 1st, 2015, this is over the time of two governments, and December 31st, 2023, BC completed 479 drug reviews. In that time, Innovative Medicines Canada, which is the representative of Big Pharma, which is, they wouldn't like that term, larger pharmaceutical companies, the brand name pharmaceutical companies, who I meet with regularly and work with on lots of issues, has stated during that time that 39 of BC's coverage decisions were inconsistent with other provinces. Those occurred over that period between 2015 and 2023. But what that also says, as the member will know, both to defend Minister Lake and myself, I suppose, against the criticisms from Innovative Medicines Canada, is that in 90% of the decisions that we were aligned with other jurisdictions. We also have outstanding levels of coverage in our pharmacare program, better than other jurisdictions. And we've been a key part of working with the federal government and their investment and their discussion of national pharmacare, but also their expensive drugs for rare diseases. And so I appreciate that that's a long answer, and I'll be shorter now, but I just want to put the context of where we are and how we are in that process, and then I'll try and be shorter. And in addition, let's say that what I will set up with the member is a process for written questions where she gets answers as she would in the speed of estimates over the next week.
Member.
Thank you very much. I'd appreciate that, because that was certainly not a short snapper. And I want to, so the point I want to make to the minister is I understand the process, I understand CADIT, I understand the PCPA. What I do not understand is how British Columbia declined to provide coverage for 31 new medications, and the list continues to grow. Those recommended medications all went through that process and a price negotiation. And during that time, Ontario declined 2, Alberta declined 3. And we're not talking about just looking at this because we want to have a big long list of medications. We are talking about quality of life for people in British Columbia that is not aligned with opportunities in other jurisdictions. I'll give the minister one example, and I have lists of them. Short bowel syndrome. You know, when we think about what's happening in British Columbia, British Columbia denies coverage for the only medicine approved to treat short bowel syndrome in children and adults. And that is not a small issue. The complications of SBS are significant. Malabsorption, dehydration, malnutrition, fatigue, weight loss. We do not cover that in British Columbia, and the list goes on, and that is the only medication approved to treat SBS. So I would just like to leave with the minister the fact that this isn't about, certainly it is about cost, and I know that that has been a principle of the decisions that are part of the decision-making process, but other provinces, you know, certainly they're not wrong in their assessment, and they, during the period of time of 2018 to 2023, only, for example, in Alberta, they only declined 3. We, in British Columbia, declined 31 new medications, and they cover a wide range. One of the most significant ones are things to do with skin, with arthritis, with schizophrenia, you name it, we do not cover it. And so I don't have time to continue to list those drugs, but I want to end this section with one question. In 2022, BC allocated $257 a person for prescription medicines, and that is significantly less than the Canadian average of $442 per person. So I did note in Budget 2024 that there is an additional $224 million assigned to pharmacare. So can the minister then tell me whether that additional funding will actually bring BC in alignment and cover access to therapies that are covered in other Canadian provinces?
Minister.
Well, just to be very specific with the drug raise, I'll just be short with this. The drug is teduglutide or Restive, which was a decision from a previous time, 2017. These decisions are subject for re-review, and that was conclusions of CADITH and the DBC at that time in the case of that drug. And I don't say that because it's 2017. These are decisions, as I say, the approach has been consistent under Minister Lake and under myself in terms of the approval processes. All drugs on the list that the member describes have either therapeutic alternatives listed on the BC formulary that provide better value for money, or a confidential negotiated price by the PCPA did not reach the cost-effective price determined by the CADITH. So that's the reason why there's some differences, and those differences have been in place under a number of governments, and certainly our approach has been consistent with that taken by Minister Lake. We believe in evidence-based decision-making, and that's what we seek to do. Equally, our biosimilar initiative has saved hundreds of millions of dollars that we can invest in the coverage of new drugs, and I won't go into that in greater detail. Finally, the numbers being used there do not include a whole series of other drugs, I would say. Like, one of the reasons why the biosimilar initiative was so important was that we were able to reinvest, I might say, on the biosimilar initiative, supported by the opposition, I think, importantly in that case, which allowed us to move together and to save money then reinvest it. Doesn't include a whole series of drugs, including the use of Avastin and other retinal drugs that aren't included on the list, oncology drugs, which is a very significant area where we may get to shortly, not considered in that part of the process, transplant drugs and others. So I'm just saying that I think we have a very robust pharmacare program that is income-based. That is the Fair Pharmacare program, remember was started in its present form under the previous government, and we've maintained it, although improved it in significant respects. So I think that discusses some of those drugs. I'd be happy as well to provide the member with information I have about the list of drugs, because that might be helpful as well, so I don't go through them and have to discuss each one, which I know the member would prefer otherwise, but the information's available. I'd be happy to share it.
Member.
Thank you very much, and I appreciate the minister's response. I don't want to debate the drugs that are on the list. I want to talk about the ones that aren't, and the ones that are impacting quality of life for British Columbians. My final question around this, I might as well link this. I was going to do it later, but I'll do it now. An issue that is very significant for many British Columbians is the issue of migraines. Without effective treatment options, many people end up in emergency departments or have an appointment with their family physician, and there are effective treatments to deal with migraines. So Migraine Canada did a recent report card and found that British Columbia, not unlike some of the other drugs that I've mentioned related to short bowel syndrome, there's a whole list of them, BC has the poorest coverage of migraine medication in Canada. A new class of medications, calcitonin gene-related peptide inhibitors, became available in 2018. However, of the 5 possible CGRP inhibitors available in Canada, BC provides coverage for only 2. Can the minister tell me if there is an intention to increase coverage for CGRPs?
Minister.
Just to report that we now cover 3 out of the 5. Vyepti was approved today, actually, and what I'll seek to do, because a lot of this information is just available, is provide this this information to the honourable member certainly this week, so that she's up to date. And on the issue of migraines, the decision to list VIAPD is an example of expanding and addressing the issue, very issue she raised.
Member.
Well, there you go. Migraine Canada will be very thrilled with my advocacy, thinking that we just got another one covered today. So that's fantastic news. I want to just do a single question here on behalf of a colleague. And, you know, the minister, if he'd prefer, I don't want us to have staff shuffle in and out here. But I'm wondering if I could read this into the record. If the minister has the answer, that's fine. If not, perhaps he could get back to me later today. But here's the question from a colleague who's involved in another set of estimates. Does the Ministry of Health have any contracts with Fair Price Pharma? And if so, to what date for the provision of what pharmaceutical products, the quantities, and what is the term of that contract?
Minister.
No.
Member.
Now that was a short snapper. I'm very, very appreciative of that one. I want to move on to talk a little bit about ER closures. We know that that has been a significant issue for British Columbians, particularly in rural and more remote communities across the province. I want to just talk for a moment. Obviously, there are challenges in many cities, but let's talk for a moment about Prince Rupert. The minister said, and I quote, he was frustrated too, end quote, by the situation in Prince Rupert. Apparently, there are a significant number of vacancies at the Prince Rupert Hospital. And if the minister feels frustrated, imagine how the people of Prince Rupert feel when the nearest hospital is a very significant drive from Prince Rupert. So I'm wondering if the minister can give me an update on the timeline and expectation for those vacancies to be filled so that the people of Prince Rupert can have some sense of confidence that if they go to the ER with an emergency situation, they are not diverted to Terrace.
Minister.
So just in the general issue, then I'll try and get kind of quickly through Prince Rupert and just talk about the initiatives that we're undertaking there. I was agreeing and Rupert talked about frustration with the frustration that people felt in the community, especially during the period of spring break when there were multiple closures. And so we've been working very hard with the community, both myself directly, the Deputy Minister of Health, the Assistant Deputy Minister of Health, and Northern Health to address some of these questions more broadly. And I'll just say this quickly, Go Health BC now employs about a couple of hundred nurses in Prince Rupert. They provided, since its creation, 28,624 Go Health nursing hours. The issue, though, in Prince Rupert was significantly doctors. And so we have been working together very closely on a new APP contract, which was first offered in January. We've been working closely with them. There's a couple of issues remaining, and we work on those issues with local doctors and with the doctors of BC. We've put in place an enhanced compensation package for the Prince Rupert Emergency Department for April, May, and June as we work through these issues, and that includes 18, and that has seen the filling of 18 8-hour shifts, and in response a further 7 full 12-hour shifts in response to the compensation package were put in place. And we're working closely with the Ministry, with the City of Prince Rupert and BCHS for long-term mitigation strategies. As the member will be aware, BCHF has been very heavily involved in supporting communities that do face diversions or temporary closures of their emergency rooms. We also have the Provincial Emergency Locum Pool, which we're building out, to which 186 doctors have signed on. And so all of these are measures, and then there's a list of measures we've already discussed, which I won't repeat, that are recruitment measures that are available for doctors in Prince Rupert. In short, there's 2 sets of issues with doctors. There's direct issues that we are engaging with them at the hospital, and there's more broadly an issue of housing in the community for doctors coming in. That's a community issue which the City of Prince Rupert is being very helpful in working with us on.
Member.
Thank you to the Minister for that answer. And again, it's one of the, and I'm not going to re-engage in the discussion we had for several hours a few days ago about the 700, net new, according to the Minister, doctors in the province. When you're living in a place like Prince Rupert or Clearwater or Tumbler Ridge, or the list goes on, Elkford, people don't feel that when their ER is closed. I'll just tell the Minister today, for example, hopefully to goodness, the Clearwater ER is open. Once again, on a highway that part of which I represent, there was a tragic accident. 2 people were killed today on Highway 5, and it sparked a wildfire on top of that. If your emergency room isn't open when those kinds of things happen, just imagine what that means for people who live in those communities. The Prince Rupert situation was devastating for people who were impacted by that. Let's move on to Elkford. So the emergency department in Elkford has been closed for 30 months. The Minister last year in estimate said that he hoped the closure would be over. The vacancies had been filled as of July 2023. So can the Minister confirm for me and my colleague that represents this area, will the Elkford ER be fully reopened on a permanent basis?
Minister.
So I'll shorten my answer just by saying I did have a discussion in detail with the member for Kootenay East on this question. Last week, I know he asked about BC Hydro and program, and he did ask about these questions, and we're in close contact with him. It's of course our intention to continue to provide that service in Elkford and to continue to do that work there, but not just in Elkford, but in Sparwood as well, where there's significant work going on. And just referred, not to give a long answer to that one, the member to the previous response I gave, and I'm in regular contact with the member for Kootenay East on that question.
Member.
Thank you. The Merritt Mayor intends to send the Minister of Health a bill for $90,000 to the province for 19 days of emergency room closures. Will the Minister and the Ministry be paying the bill, yes or no?
Minister.
So thank you, Honourable Chair, and what we are focused on is filling physician positions in Merritt. 3 positions working primarily in community and 1 international medical graduate who's completing a return of service or as a part of completing their residency and beginning practice as a physician in BC. The success of the provincial ED physician contingency locum pool has ensured urgent and last-minute vacancies at Nicola Valley Hospital have been covered, Honourable Chair, and that a contract to fund additional physicians in permanent positions in the ED is being developed with the Ministry of Health that offers physicians alternative compensation to fee-for-service. We've had an APP offer on the table for some time, and we work closely with the Mayor of Merritt. The member will know the Mayor of Merritt brought these ideas to the Regional Hospital District and was not successful in that. We won't, what we will be doing, and while we won't be paying the bill, we will be continuing to work with Mayor Getz, who I've worked regularly with in this process, to continue what I think has been a successful effort to fill physicians, and that's what people want there. They want physicians and they want nurses, and they understand that the Mayor of Merritt is taking steps to raise the issues of his community, and I completely respect his approach and his advocacy for his community, and have been working with him closely on these issues. I would say, in addition, the Mayor of Merritt has offered temporary accommodation to people, and has found some opportunities there, and I'm very appreciative of that as well. So as you can see, that the situation has significantly improved since last summer when we raised these issues, but it's not finished yet, and it's why we continue to recruit and add physicians to the Merritt Hospital, as well as pursuing the APP agreement that has been helpful at other hospitals, and we believe will be helpful at Merritt. We hope to have a solution on that soon with the doctors of BC and the doctors in Merritt.
Member.
Well, thank you, and I certainly agree with the Mayor's approach. I had the opportunity to meet with him and spend time with nurses in Merritt last week, and there was a significant sense of distress. And nurses, in fact, described for me the fact that they are experiencing moral distress and burnout. And that is not unique to Merritt, although Merritt has had 22 closures, service interruptions, over the last 2 years. And the minister noted that, there was funding that was supposed to stabilize physician staffing in October, but staff at the hospital say it's not enough. And in fact, nurses said, and I quote, "Interior Health must acknowledge the crisis at their worksite and address the systemic staffing challenges that are resulting in untenable working conditions for nurses and the deterioration of patient care in the community." So I guess I just want to, emphasize for the minister, it's one thing to make an announcement, it's another thing to actually see those changes make a difference for the people of Merritt. And again, if you look at where Merritt is situated in this gigantic province we live in, whether it's summer or winter, there is significant transportation. I don't know if the minister's driven it recently, but industrial traffic along the Coquihalla and through those corridors is extensive. So it's not enough to be able to say, okay, the ER isn't open today in the middle of a snowstorm in the Coquihalla. So I wanted to raise for the minister the fact that there continue to be systemic staffing challenges at Nicola Valley Hospital, and that I applaud the mayor for actually standing up and speaking up for his community. I'm disappointed that the minister won't be paying the bill for the time that the ER was closed, but I do appreciate the fact that we have situations like this all over the province. So I appreciate the time spent on Merritt. I wanted to raise ever so briefly also South Okanagan General Hospital. The minister described an arrangement that he had made as stabilization arrangements. That arrangement was signed on September 29th of 2023. And in that news release, again, a news release, I will quote from that release, and it said, and I quote, "With these service contracts, all patients and nurses will benefit from more regular on-site physician presence, which will help emergency rooms in these hospitals remain open," end quote. Well, since October, all 18 closures that have occurred at the South Okanagan General Hospital have been due to limited physician availability. So clearly, the problem is ongoing and the solution isn't working. So I'm wondering if the minister, or he doesn't have to provide it to me now, but he could provide that to me at some point, the details of the $7.5 million that was announced, how much was allocated to Oliver to stabilize emergency services there, and how much of that subset has been spent to date. Member
for Boundary, Similkameen.
Thank you very much, Honourable Speaker. May I have seek leave to make an introduction?
Is leave granted? Please proceed, member.
Thank you very much. I see in the gallery we have another group here from École Glenbrook in New West, and so if the House would please make them feel very welcome and excited that you get to be here to see the back and forth here regards to the Ministry of Health. So welcome.
Minister of Health.
So with respect to South Okanagan General Hospital, we've been working closely with doctors in the region and with the Mayor of Oliver to work on these specific issues. On September 29th, as the member stated, we approved an APP contract application for South Okanagan General Hospital. What's required at that point, we don't make anyone go off fee for service. These are always negotiated and discussed. A significant discussion with doctors at the hospital, and so the funding was approved and the supports were improved, and the physicians were required to accept a contract offer, which they did on December 20th, 2023. I think the money in question that we talked about was about a number of communities, and this was one of them. At the time of the signing, 10 physicians signed as permanent contract members, and they committed to providing 5.5 FTEs of service. And we also brought in 22 locum physicians. The result has been a significant improvement in stabilization of the situation. Not perfect yet, but still a significant improvement as a result of the APP contract. And just to explain to people who are listening why APP contracts are useful in this case, as opposed to, say, a fee-for-service contract, is in a community such as Oliver or such as Merritt or even such as Prince Rupert, is that it ensures shift coverage and people being paid for essentially the time they served and not the number of patients they see, which is a significant impediment. Previously, In a lot of communities, the group of doctors in the community would work together to fill ER shifts. That situation is changing. It's just not the same as it was. And that requires a change in approach, and why we are pursuing in a number of places, including Prince Rupert, including Merritt, and successfully at South Okanagan General Hospital, APP contracts. And in addition, we're recruiting for one additional position for emergency medicine in South Okanagan General Hospital. The total value of the APP contract for the FTEs in question is $2.82 million. And obviously, this is significant work, and I want to thank the doctors in the community who advocated for this, who wanted this. We negotiated it, we funded it, it came in place. We went through the details of it, which took between September 29th and December 10th, and it's now in place, and there have been improvements, and we have to make more improvements.
Member.
Well, thank you to the Minister for the response, and I appreciate the details. But, you know, let's be clear. We see the Minister basically around the province dealing with one-of situations all over the place. I have pages of closures, whether it's in the Interior Health, 100 Mile, Ashcroft, Barrier, Castlegar, Boundary District Hospital, South Similkameen, Lillooet. Then let's move into Northern Health, Chetwynd, Fort St. John, Fraser Lake, Houston, Hudson Hope, Kitimat. The list goes on. And so while I appreciate the fact that it's let's get to this one, meanwhile, there are closures all over the place. And it has enormous impacts on people across the province. So I don't have time to go through all of the various locations and the number of closures. I certainly have a chart, but I do want to point out that in the case, for example, when you look at Oliver, where this was supposed, Boundary Similkameen, we look at Oliver as an example. The number of service interruptions in 2022 was 4, 2023 was 31, and 10 closures after October the 18th, when the announcement was made, were limited physician availability, and this year, in 2024, we're already up to 8. Why? Limited physician availability. So again, we announce, we roll out the money, we go and say it's going to be stabilized, and sure enough, we continue to face the same issues over and over and over again across the province. So, and you know, British Columbians who live in rural and more rural and remote communities deserve quality health care wherever we live in this province. So with that, I'm going to move on. I do want to go back for just a moment. The Minister, and I'm sure he did not mean to do this intentionally, but the 400-plus drug review he referenced is not an apples-to-apples comparison. So the list includes generics, biosimilars, HIV and cancer therapies, and likely other program spending that pharmacare is not responsible for. I was speaking specifically to pharmacare. Between 2018 and 2022, BC reviewed 99 drugs that had a CADIT recommendation and the PCPA letter of intent. They opted out of 31 drugs during that time, and that is an opt-out rate of 30%. And that was the point that I was trying to make when it comes to, again, quality of life, availability of options for people that are not available in British Columbia, that are available in other parts of the country. I wanted to raise an issue, and it's a nursing issue. I wanted to raise it because as the Minister well knows, I spent a lot of time on the road last week and spent some time with nurses throughout the Interior Health Authority. I actually didn't believe this was happening, but apparently it is, and I would like the Minister and his staff to look into it and assure me that this is, if it is happening, it's going to be fixed. We have, and I have a series of you know, I have information from 2 different nurses that have received bills from MSP for ER visits for first aid within their hospitals after a workplace safety incident occurred. So let me give the minister an example. A nurse from a hospital had to have treatment for blood work pertaining to a safety incident that occurred at work involving patient blood body fluid splash to her eyes. Today, this is the day that I got it, she received a reminder bill in the mail regarding the first ER visit for this first aid visit. The total cost she was being asked to pay is $521. Now, I can assure you that if nurses in British Columbia are getting bodily fluid splashes in their eyes, they should not be paying MSP. So I will happily share the location later with the minister of the two nurses. But again, in two cases specifically, according to these nurses, they needed to have first aid treatment, and they were sent bills in the mail as a result of that. So it's really important that if there are body fluid exposures, that actually nurses should be taken care of. Can the minister just confirm that he will take a look at that situation?
Minister.
Of course, we'll take a look at the situation. We resolve issues with the BC Nurses Union all the time, and in our workplace, as we've talked about many times, there are 230,000 people who work across the healthcare system in BC. The cases seem fairly straightforward, and I'll have my staff work with the nurses expeditiously to ensure that the situation is resolved.
Member.
Thank you for that. I want to move on to talk about something that we're all very concerned about, and that is obviously medical imaging and cancer treatment in the province. So I want to start with that. Even just today, I received another email from a constituent in my riding, and I can barely read through the email because of the significant delays that this person is facing, and they are dreadfully afraid that cancer has already spread before they get a chance to have the treatment and imaging that they deserve. So I'll remind the minister that I wrote to him regarding medical imaging wait times last year, and I did that in a follow-up to our estimates discussion. I would like to know the data the data breakdown wait times for diagnostic imaging for priority 1 through 5 examinations per health authority. So specifically to the minister and staff, and again, if you'd prefer to provide this to me later, that's fine. What are the wait times for P1 to P5 examinations by ultrasound, computed tomography, magnetic resonance imaging in Vancouver Coastal, Fraser Health, Island Health, Interior Health, Northern Health, Provincial Health Services Authority? So I'm wondering if the minister would be prepared to work through that data and provide it to me. I'd like to know also the vacancies with respect to medical imaging professionals in BC. How many radiation technologist and radiologist vacancies are there currently?
Minister.
Thank you. And what I'll do is provide some comprehensive responses because we have the information as we've prepared it, but it may be different from what the member wanted. So I'd be happy to provide that. Just in general, I would say, and she'll know this from our past estimates debate, the broad issue of medical imaging is one of significant importance to me and to the government, such that we've increased our per capita rate, for example, for MRI exams in the time I've been Minister of Health from 36 to 58. That means from 174,000 MRIs to 314,832 in a relatively small period of time and during a pandemic. This, with respect to CT, similar situation. There are, for 23-24, 983,526 CT scans. That's a 41% increase over what it was in 2016-17. We've seen our wait times broadly in diagnostic imaging improve against other jurisdictions in the country, in many cases dramatically, especially at the 90th percentile, such that the MRI wait time in days at the 90th percentile was 273 in 2016-17, and that was down to 145 by 2022-2023. And so what we've seen is a very significant investment. I think people are going to reflect on that. Sometimes we get into the discussion, when did what thing happen and what not happen. Every one of those MRI scans, every one of those CT scans involves multiple work by skilled people. So that is a massive increase in capacity over that time that was achieved by extending the working time of MRI and CT machines through the day. We only had one operating 24/7 when we became Minister of Health. We have, I believe, 8 today, and we've gone from 7 operating 7/19 to 19. We've gone, the number of MRI scanners has increased in my time from 25 to 43, and the number of CT scanners from 63 to 72. That's net new in the public system. And the most significant places where the most significant increases and improvements have happened have been in the Northern Health Authority. And that doesn't mean that they're not challenges for people. It doesn't mean that when you're at the 90th percentile, 50th percentile, and there's a wait time at all, when you need an MRI or CT scan, you want to have one right away, and I understand that. And that's why we have built out so much capacity, and there is more to do. One of the things we see in hospital when we go to different communities, whether it's Fort Nelson, which is looking for a CT scanner, whether it's Kitimat looking for a CT scanner, is not just the quantitative, but the qualitative response that sometimes can mean a reduction in hospital stay if you have diagnostic equipment in that particular place. So what we've seen is a very dramatic improvement in diagnostic services around the province, and that doesn't mean we can't do more. I disagree with that, and I'll provide some of the detail and information that the member asked, perhaps by letter and not a long time from now, but as the session goes on.
Member.
Let me just read a quote for the minister. This was from March 22nd this year, 2024. And I quote, this is from the president of the BC Radiological Society. Medical imaging is at an all-time crisis. It's a lack of resources, a lack of personnel. It's just all come together with the post-pandemic backlogs, increasing ages of the population. There's many factors that are resulting in these delays, but it's making it really difficult for physicians to get the initial imaging that they need for diagnosis or to screen for workup of cancers, for diagnosis of cancers. Even just image-guided biopsies are behind as well. So it's putting a lot of anxiety both on the clinicians, but particularly on the patients. That's the circumstance that people are facing in British Columbia. So, you know, the minister can speak about added capacity. On the ground, that is not what people feel. And in fact, the distress that radiologists and other specialists are feeling has been described to me as moral trauma. because they can't do the work they're called to do. So I appreciate, the minister continuously referring, massive investments and massive increases. Those aren't my words. That's the those are the words of the president of the BC Radiological Society. So let me ask another question, if the minister can provide this information to me as well. And he doesn't have to do it at this moment, but what are the current wait times for diagnostic mammograms? And again, I'd like to see that in each health authority. But I'd like to move on to financial pressures facing community imaging clinics, because I raised this last year, and in fact, clinicians themselves, specialists, raised the issue. And they note that the pressure has only gotten worse since then. So basically, clinics are struggling to keep updated equipment, and some aren't even replacing mammography equipment specifically. So I'm wondering what the minister what his plans are to specifically address the increased operational cost pressures. And if you look at what again, the president of the radiologists has said, and I quote, "It's becoming very difficult for some of these clinics to even keep updated equipment. So some are even choosing to not replace the mammography equipment they have once it breaks down because it's just not worth it." I cannot imagine what we will do with fewer pieces of mammography equipment when we are facing the crisis that we're already facing. So could the minister provide me with some hope, and more importantly, British Columbians, about the plan that he has to address increased operational costs for community clinics?
Minister.
Okay, just a few things. We talk about people on the ground. 110 MRI technologists, FTE technologists in 2019, 246 today, which is, I think, which is more than double. And the place where the most significant percentage increases is in Northern Health. In terms of sonographers, 386 in place. Minister of Health, 537 today. So those are the significant increases on the ground. The member asked for some questions and details, and I have some of the answers, but I think what I'll do is not go through the full list of answers, but rather to provide this information and the significant reductions in significant areas in terms of wait times. I want to answer so I didn't want to go give an 8-minute answer on all of that, but that's a short version. I think in terms of the workers for the HSA, where the bargaining unit is increased by 26%, it's a key bargaining unit, and you see the very significant increases. That is a demonstration in terms of people, not just machines and exams, of the increase we've seen. We're working closely on the community imaging clinics. We have a working clinic with the clinics that involves both Associate Deputy Minister Mark Armitage, Assistant Deputy Minister Kirsty Anderson, that is dealing with this issue with the BC Radiological Society. The members include health authority staff, the society itself, physicians, and others, to address the key issues that they have raised with us about their cost pressures. The recommendation, they will complete their work and issue a report on or before June 30th, 2024. So we are working actively and on the ground with radiologists around community clinics as well. We've seen the very significant progress against other jurisdictions we've made in the provincial system on diagnostic care, but the member is right. that community clinics are very important, and that's why, in particular, the mandate of the ultrasound working group to address these key issues, which include clinical placements, significant cost pressures at Health Human Resources, why that is such a priority for us and why we're working so closely, again, with those working in the field.
Member.
Thank you to the Minister. I guess I just want to reiterate, you know, we can stand in the House all day and trade numbers and quotes. When people have to wait 1.5 years to get surgery when they have a fist-sized tumor, I don't think that they think the words mean very much when it's we've had significant increases and we're adding this and we're doing that. The fact of the matter is that may be happening. But what's also happening is the BC Radiological Society is telling this minister that we are at an all-time crisis. Medical imaging is at an all-time crisis. That wasn't like 2 years ago or in 2016, March 22nd, 2024. And people just want to hear, just once in a while, that there's an acknowledgement of the anxiety, the distress, and not just for patients, but for healthcare professionals who cannot deliver in a timely way in British Columbia. Anyway, let me just continue on. In March, there were 2 separate incidents at Surrey Memorial Hospital where the CT scanner at Surrey Memorial was unavailable overnight. Again, due to staffing shortages. It's the busiest ER in the country, and losing access to a critical piece of equipment for any period of time is unacceptable. The Medical Staff Association says there should have been improvements and investments over the past year, and they are very concerned about the lack of access to critical imaging resources. They are warning that no access to a CT scan for even a few hours could lead to catastrophic delays in diagnosing. Can the minister provide for me a response in terms of what action he is taking to make sure that the critical piece of equipment at Surrey Memorial Hospital is staffed at all times?
Minister.
I think I said in the previous answer, for example, on MRI machines, we didn't have them open overnight. So by definition, I guess they couldn't be off on 2 nights. And that's frequently the case. Plus the problems, we've dramatically increased the numbers and the hours by significantly increased the training in the staff. And we're going to continue to have to do that. I would argue both in terms of sonographers, in terms of medical radiation technologists, in terms of laboratory and X-ray technologists, with a turn to everyone across the sector. It's why we've increased training spaces as well in these areas, because these are frequently some of the biggest challenges you face in healthcare. A lot of discussion always of doctors and nurses, and we've talked about the remarkable year we had last year in recruiting both. Doesn't mean there aren't other issues, and I don't avoid that. I go and meet with people directly and answer their calls and listen to them all the time. But you know, in areas where we have, in terms of our technologists, in terms of our allied health workforce that has shown just exceptional work by post-secondary institutions and health authorities in terms of increasing the number of people involved, more than doubling MRIs, MRI techs working in the province, as we basically doubled the number of MRIs. That's a significant success, and we need to reflect on that as well. So part of the reason, the way in the medium term you deal with these issues is increasing training spaces, and we're doing that. For example, the 336 new allied health spaces we put in place in BC, the recruitment we're making in key areas. We talked about radiation technologists earlier, and all of that work is being done to ensure that staff, such as the staff of Surrey Memorial Hospital, are supported. We also have to do work, I would say, and this is important, work on the other side of it. When you increase, member says, well, people don't feel the increase in number of exams, whether it be the hundreds of thousands more CT scans, the hundreds of thousands of more MRI scans we've done, and all of the work by all the healthcare workers and specialists involved in that. We also have to, I think, take some action and working together with the professionals to ensure there's not either duplication or unnecessary scans, so that people who need the scans get them more quickly as a result. But the results have been good, and sometimes, in the case of Surrey, I can absolutely, and will respond specifically on those 2 days and what happened and what we're doing there, but basically across the system as well. We have to recruit and train more people. If we're going to add CT scanners, as we are in many communities, then we're going to have the people to make those go, including the radiologists on the MRI and CT side, and that means the significant increases in training that we're making.
Member.
Thank you, and I am obviously, because of the timing of this session and the fewer hours that we have, I am pressed for time. I have an hour left, and I want to move to cancer care, please. I'm just gonna read these out. I don't expect the minister to have it today, but I'm hopeful that he'd be prepared to provide the information for me. So what I'm looking for are the number of vacancies for full-time equivalent positions, and I'm wondering if the minister has the information broken down by health authority. So I'll just list the positions that I'm looking for, and obviously the minister has a large army of staff, so I'm sure they'll be able to get the list. So by health authority: medical oncologists, hematology oncologists, neurological and gynecologist oncologists, radiation oncologists, surgical oncologists, radiation therapists, oncology nurses, and medical physicists. So those are the categories I'm interested in terms of the number of vacancies for full-time equivalent positions by health authority. So I'll just leave that. I'm sure the minister isn't going to read them all out one at a time. So I want to just look at BC Cancer's data and analytics when it comes to wait times. As I understand it, BC Cancer's data and analytics division provides performance benchmark indicators to the minister. And that was obviously it was noted in the Premier's transition binder in 2022 and the Minister's 2023 estimates binder. So I'm hopeful that the Minister can share for the most recently reported quarter what percentage of patients were treated and seen within benchmark wait times? And I'll give the minister the categories. So obviously the information is available because we've seen it in the Premier's transition binder and the minister's binder. IV chemotherapy treatment, radiation therapy treatment, radiation oncology consults, and medical oncology consults. Could the minister just confirm that he could provide that information to me?
Minister.
Yes, and what we'll be doing very shortly is doing a report on the first year of the 10-year cancer plan. In advance of the public release of that report, Dr. Chi and Deputy Minister Brown can provide the member with a full briefing in advance of that. So we're assessing the plan over its first year, where we need to do more, what the successes have been. For example, and just say this, and we'll get the FTE numbers. I have one of the answers on FTEs that the member was asking for. We've seen a 16.2% increase in 1 year in physicians. That's a headcount increase of 92 physicians, of which 71 were oncologists. An additional 20.9 FTEs have been hired but not yet started. So this leaves for physicians a 14.3 FTE vacancy for physicians. So that is real progress, and that makes difference for people. Keeping in mind something that the member and I discussed last week, I think, the significant increase in number of people in MSP, which just brings about more people who require cancer. So we have to keep doing this. 30 new FTE radiation technologists have been recruited since April 1, 2023, when wages were increased under the collective agreement. A further 6 have been hired but not yet started. 21 further graduating students have accepted conditional offers of employment, 10 recruited nationally and 11 from BCIT. The entire graduating class, that is great news. Net 135.7 regional staff FTEs have been added to cancer centers since the start of the fiscal year. That's a 10.5% increase in 1 year. And there is, as of P12, a total, and this is a reduced total, of 254 FTE vacancies. So that's gives some of that as answers on the specific issues. We'll either provide those to the member in this time, or we'll provide them in a specific briefing we'll have for the member in advance of the release of the report on the first year of the cancer plan.
Member.
Thank you to the minister. And what I would appreciate is the more specific the data can be, the better, so we can have a good understanding of what the gaps look like and what progress has been made. So it was interesting to note that in February of this year, the minister was actually able to state that Kelowna Cancer Centre had the highest number of people receiving radiation therapy within wait times. And I think that was given as part of the rationale for why fewer people in the interior chose not to or did not need to go to Washington State. So that would make me believe that the minister has the data broken down by cancer center at the cancer center level. So I am hopeful that that I would also be able to see by cancer center and by health authority the same descriptions that I've provided: IV chemotherapy, radiation therapy, radiation oncology, and medical oncology. Because obviously, if the minister knows Kelowna, he must know the numbers at the cancer center level. So I will leave that question on the record for the very specific data. I look forward to receiving it. I wanted to just get an update on the Bellingham radiation therapy. I'm sure the minister can imagine what it's like for people who have to leave home to get critical radiation treatment. So can the minister tell me how many patients in fiscal 23-24, or as recently as, if it's up to date, fine, have been referred by radiation oncologists for treatment in Bellingham? How many have started treatment, and how many have completed treatment?
Minister.
So, member is quite right. One of the reasons why, and I said this is why I said this in the House, why the Bellingham program wasn't designed for interior health, was that the wait times were in much better shape in interior health than anywhere else. And that was the reason people obviously would rather go to Kelowna than go the long journey just south of the border in Bellingham. And so let me just take the member through the people who have received and are eligible. Remember, this is a choice for people, and that it's obvious, I guess, that the largest group of people who have chosen to get treatment are from the Fraser Health Authority because it's closer to Bellingham and it's a more direct route, and because there are a lot of people in that health authority. So let me take through the numbers. 884 patients who are eligible and agreeable for treatment in the United States. Post-screening cancellations, 87. This is as of, by the way, April 22nd. So really it started in July, essentially, these referrals. So that's that period. Patients that received a U.S. radiation oncologist consult, which is required to begin with, 739. There were 11 post-consult cancellations. 703 patients have started treatment. Currently, this week, receiving treatment in the United States, 50, which is the maximum. And we've been between 46 and 50 basically every week except the Christmas weeks in the last 6 months. So we've been at the maximum contracted amount. The number of patients that have completed radiation therapy in the U.S., 654, of which 494 are for breast cancer, 160 are diagnosed for prostate cancer. I also have the numbers by health authority. I won't go through those now, but I'll share those with the honourable member. That might be the easiest path. But just to say generally, that the health authority that's had the most participation is the Fraser Health Authority, partly because of proximity and the sheer number of people in the Fraser Health Authority. So that's the disproportionate group. That helps whenever we expand the access to care. Obviously, that helps addressing issues of waiting for care, and we want to get that right away, which is the reason why we engage in this initiative. But I would say this, that 27 patients have completed treatment from the Northern Health Authority and 97 from Vancouver Island Health Authority. So it's not just Fraser Health, but those are the health authorities involved.
Member.
Thank you to the minister. Could he just confirm that he said that the number was 703 people that have started treatment in total?
Member.
Thank you. And when the data is shared, could the minister also ensure that if the numbers are included for people who have declined or to actually participate in the Washington program, and if there are those who have failed screening and may still be waiting for treatment, if he could include that information. I'm wondering if the minister can tell me if there have been any updates or extensions to the 2 contracts since each of them was originally signed.
Minister.
No.
Member. Member.
Or that's me. Get up. It's straight. Oh, yes, that was a short. I'm never prepared for a short snapper from the Minister of Health, so that was very good. I also I want to move on to something that actually the Premier said. And in his year-end interview, one of his year-end interviews, he made a commitment to releasing wait times for chemotherapy and oncologist appointments. I'm wondering if the minister could provide me with a timeline for when that data would be made publicly available.
Minister.
I'll be shortly reporting on the first year of the cancer plan. It will include data such as that. And if I have it in advance of that data that I have in advance of that, in any event, we'll commit to giving a pre-briefing to the member, so she'll have that on the day. She won't just be responding immediately after the conference, but she'll have the information. But if we have it beforehand, I'm happy to share that as well.
Member.
The other thing that the Premier talked about was that he actually said that, we need to make much faster progress in cancer care. So I'm wondering if the Minister can, and perhaps this will be included in his upcoming report, are there exact and specific targets that have been set for cancer care improvement? And there is, what I would like to know is, are there those targets set in place? And is there a gap between the targets and the latest wait times for chemotherapy and oncologist appointments?
Minister.
Yeah, those targets are on the record. I'll be happy to share them with the member. We'll just give a member an example on radiation therapy because we were talking about that, but we can also do that in terms of consults. In terms of radiation therapy, and this is in P12, so the fiscal year is divided into 13 things, so this is probably February to the middle of March. In that case, 83% of patients received treatment, radiation therapy within 4 weeks in P12. 90.1% were treated within 5 weeks. So it's very clear our goal is to achieve 90% within 4 weeks. So that means ensuring that shows that we're close to that, but that we have work to do. And so there are targets in every one of those areas in terms of treatment and targets that, and it's those clinical targets that we intend to hit.
Member.
Thank you to the Minister. There was a new expert panel was appointed to advise BC Cancer. I'm wondering if the Minister can provide me with the panel's specific mandate, their terms of reference, perhaps tell me whether they've met. Have they submitted recommendations to government? Will recommendations that, if government has received recommendations, will those be integrated and when into improving cancer care service?
Minister.
So there's two committee structures that were put in place. The first is the Executive Provincial Steering Committee that was formed in November 2023. It involves the Deputy Minister of Health, but also three prior experts that the member will be familiar with: Don Carlo, Susan Riley, Tom Keane. And they meet on a regular basis, I think bi-weekly, to oversee immediate actions. The international committee that we referred to as well, the panel is does meet and will be meeting in person next week, and that includes Professor Mark Britnell from the Global Business School for Health, University College London, and he has other titles, needless to say, Professor Dorothy Keefe, who's the Chief Executive Officer of Cancer Victoria, and Dr. Craig Earle, who's the Chief Executive Officer of Canadian Partnership Against Cancer, and they'll be meeting, their next meeting will be an in-person meeting in Victoria next week.
Member.
Thank you. I appreciate the information, and as I've said numerous times, data is one thing, words that we share in this House, but anyway, when you have a cancer diagnosis is too long. And all of us are hearing absolutely terrible stories of people who are afraid and worried. We have healthcare professionals who are finding it devastatingly difficult. So there is a lot more work to do. I look forward to receiving the information from the minister about wait times and looking at the gaps that exist. And I think it's important to acknowledge that people are just worried, and they're feeling often a lack of hope in the system. So I want to move on to capital projects. I'm going to start very quickly. The minister will not be surprised to know how disappointed I was. Yes, we're getting a parkade, but I do not see in the budget the plan for University Hospital of Northern British Columbia. I've met with doctors on a regular, nurses, healthcare professionals, patients on a regular basis. And I don't think it's a stretch to say that the situation at UHNBC is dire. It is not something we can simply continue to push further down the road. There was an announcement, more than one, about a new patient tower, cardiac unit. We continue to see investments being made elsewhere. The business plan phase, that was one of the commitments. That takes 12 to 18 months. When we think about this, we've seen those deadlines move further and further and further away. And I am deeply concerned for the people of Northern British Columbia. As the minister knows, that is not, that hospital serves an enormous geographic region in British Columbia, 2/3 of the geography of the province, actually. And so, I would like the minister to provide me with specific details of when the people who are served by UHNBC will see shovels in the ground.
Minister.
Thank you, Honourable Chair. First of all, because I'm talking about Prince George, I'm going to wait. So the pre-works is really important. I, like the member, want to proceed with the project. And the pre-works, as we've seen in other projects, you have to do the pre-works on this project. You have to do work on the site to prepare the site for the larger works that come later. And so I pushed forward vigorously with the pre-works, and the contract has been let, and they're starting construction soon, and that's part of the project. So if we had not done that, then everything would be delayed for the pre-works. So that's not a small project, and it's not just a concept plan approval in the 10-year capital plan, but it's not just a business plan approval, but a proof contract, and that we're proceeding to break ground, and that is part of a broader project. And with respect to the University Hospital project, we need to proceed to business plan approval. I can tell the member that we are close, but that the project has begun because the pre-works have been are underway, and wherever you were starting, they were always going to have to come first. And I didn't want to wait. I didn't want to go through business plan approval for the whole project, wait for the pre-works. I want to go on that project. It's a high priority project for me. I know, however high a priority it will be for me, it's always going to be a higher priority for the member. And what we've talked about are the priorities there, which is improvement on the operating room side. They're operating in 1979 operating rooms, and our brilliant staff at the hospital do a great job for patients and continue to do at that hospital, but they got to be better. The other place is mental health and addictions care, and I think, I'm not telling the member anything she doesn't know, but other people may be interested to know that even the operating rooms is not as urgent, I think, a need as making, if you compare the unit, I know the member was in the Interior recently, you compare the unit that's been built at the new Royal Inland Hospital with the unit that people have to get well in at the University Hospital in Northern British Columbia. It's a huge difference. Cardiac care is something we want to bring closer to home. So the reason why we're doing the pre-works, it's not just, you know, I know the member has to say these things and everything else, it's not just a parkade, this is crucial and integral to doing this project. The reason we are proceeding getting that work done is it's integral to all of the other work being done. And we're close, and I can assure the member, I always tell her when I'm going to Prince George, I'll be telling her on that occasion. That will be a good day for the people of Prince George, but one of many, because we've got a lot of work to do to build that project together, both with obviously with the Regional Hospital District, ourselves, driving that process forward. But I believe, profoundly in the need for this project. It's a priority for me. And there's always a debate in Northern Health about what should go. A long wait for projects in Dawson Creek, proceeding with that, long wait in Fort St. James, proceeding with that, long wait in Terrace, proceeding with that. This is just as important as those projects, and I appreciate it's a wait. I also will tell the member that the reason we're proceeding with the pre-works is the priority we get to getting this done.
Member.
Well, thank you to the Minister for that response. He's right about the fact that I do have to say those things. He should also know it is one of the motivating factors for wanting to continue to do this work, because there is unfinished business. And we have operating rooms that are absolutely not acceptable for the unbelievable staff that we have at UHNBC. And in fact, what we know and what we have seen, and I've met with them, is OR time is shrinking, it is not growing, and at a time when we have a crisis in healthcare, we need ORs running full out. We can't do that at UHNBC. We have surgeons that are worried about the ability to keep their credentials at UHNBC because they have to actually have a certain amount of operating time. And instead of getting hours per week now, they're getting hours per month. That is simply not acceptable in a region as large and as complicated as mine. I will end this to move on to another project in a moment, but I do want to say that I also want the Minister, when you think about the geography that UHNBC serves and the nature of work that is done there, to not consider a helipad is short-sighted and inappropriate in my mind. When you think about this, Vancouver, New West, Campbell River, Comox Valley, Kelowna, and Kamloops all have rooftop helipads, and that saves precious time when a patient's life is at risk. So I think that is absolutely essential and needs to be considered in the UHNBC project. I'm a very strong advocate and supporter of making that addition. I would also ask the Minister and his staff to look into the circumstances related to the shuttling of staff. As you can imagine, when you are removing parking spaces, you have to move staff back and forth. And I've been advised that there are going to be shuttles running to transport people back and forth to the hospital facility, but that they are not, that they don't work for every set of employees. So for example, if you're getting off at a certain time, you will not be supported by a shuttle. So I would ask the Minister to very quickly look at what is being done to accommodate unbelievably hardworking healthcare workers who need to get back and forth to where vehicles will be parked as the project proceeds. And I received a significant, I was very concerned from a young female healthcare professional who doesn't fit the shuttle hours. But I, for one, do not want to see her having to worry about being back and forth in the downtown area of Prince George without appropriate shuttle arrangements. So I'm hopeful the Minister could actually take a look at that quite quickly, and someone let me know whether that's a situation that can be dealt with or if it indeed is an issue. I want to move to the Surrey Memorial Tower. On March the 11th, actually, the Minister and the Premier went out and announced a new tower at Surrey Memorial Hospital. It sounded like a formal concept plan had not been completed, but I'm assuming before you make an announcement about a new tower for Surrey Memorial, there must have been some kind of Treasury Board submission. Can the minister confirm on what date Treasury Board approved a new tower at Surrey Memorial?
Minister.
Now, Honourable Speaker, this is an area which the member is quite familiar as a longtime member of the Treasury Board, and her colleague from Kelowna will also be quite familiar with that process. So I will not be giving that detailed answer, as she knows that I can't. But what she knows is that to be in the 10-year capital plan, whether you're the University Hospital in Prince George or the Surrey Memorial Hospital Tower, you have to have approved money in the 10-year capital plan of the government. And of course, the Surrey Memorial Hospital Tower has approved money in the 10-year capital plan of the government, just as UHNBC does.
Member.
Can the minister confirm the amount of money that is in the 10-year capital plan for Surrey Memorial?
Minister.
Honourable Chair, the member, I was smiling because I know the member has fond memories of her time on Treasury Board, and she knows the answer to this question before she asks it. But she also knows that we have an exceptionally dedicated Treasury Board staff and Treasury Board team, and that that process in every case, I don't just mean under this government, I mean under every government, is taken extremely seriously. And so what I can say is that you have to have the money in the plan. There's all kinds of reasons, including reasons of negotiation, why we wouldn't answer that question, why ministers have never answered that question. Not when the member was on Treasury Board, not when I'm on Treasury Board, which I am and have been since 2017. So I'll just leave it there, except to say that I think the Surrey Tower is a needed project and a great project. And I go around. We have, I believe, 34 projects over $50 million at business plan stage now. This is the largest health capital plan in history. There had been a capital deficit on many of these things. Many of these projects have been waiting a long, long time to go forward. When I became Minister of Health in Surrey, we've approved and are going forward and have contracted with Ellis Don the building of a second hospital and Action and approving the Surrey Tower, which is going forward at business plan stage and, of course, is in the 10-year capital plan of the government.
Member.
Well, I gave the minister an opportunity for a short snapper, and he did not take that. Can the minister then tell me what is the timeline for business plan completion? That shouldn't be bound by Treasury Board. Business plan completion and the anticipated start of construction.
Minister.
Business plan would be 15 to 18 months.
Member.
Thank you. Can the minister confirm that the tower will be able to deal with heart attack, trauma, and stroke? Will it be a level 2 trauma center?
Minister.
So let me just go through, rather than doing them one by one, just go through the types of beds that are in the hospital. There are medicine beds related to mental health and substance use. There are stroke inpatient beds, pediatric inpatient beds, surgical inpatient beds, of course, operating rooms, and obstetrics beds, NICU beds, and those are the key areas that you would see in the clinical services plan impact on the hospital, if that's of any assistance to the member.
Member.
Well, I just wanted to, I wanted the minister to acknowledge that, patients who need care in particular areas need it right now. And nearly 1,400 patients are transferred every year by ambulance, mostly to Royal Columbian. And when you look at the three top reasons, they're heart, stroke, and pediatric specialty care. And so if you start, if the minister looks at that, we're not sure when the new tower is going to materialize, but we do know this, that, the site medical director has said, we still have long waits in our emergency department. We still will have hallway beds for a while. So what is the timeline for the resources that Surrey desperately needs to be able to treat a population that is growing at vast capacity? We know how quickly it's growing. When will they no longer have to go elsewhere for heart, stroke, trauma, and other critical care?
Minister.
Well, thank you very much, Honourable Chair. And the member will know that we're building a second hospital in Surrey in advance of the tower at Surrey Memorial Hospital. That this government has a very different approach to that than the previous government. We're in short staffer time. I can take that. The rest of that answer is read. The member will be familiar with it. We took 30 initiatives in June of 2023 to make improvements at Surrey Memorial Hospital. Of those initiatives, 14 are fully in place, 10 are partially complete, 6 are in the planning stages. With respect to cardiac, we're adding a cardiac cath lab to the Surrey Memorial Hospital. That process is well underway. We're significantly increasing renal supports. We're significantly increasing and have taken action on specific HHR issues. I can go through in detail with that. The member will have our most recent update on those 30 initiatives, but every one of them have seen progress. Just in particular, the targeted recruitment of international recruitment of medical and health staff, 77 internationally educated nurses since 2023, January 2023, 71 internationally educated physicians, and the nursing staff, 122 new nursing grads, and 164 employed student nurses, and the list goes on and on. So I'll just share that with the member, the most recent update of the very specific and immediate actions we've taken at Surrey Memorial Hospital, 30 actions, in addition to a second hospital, in addition to a primary care network, in addition to 2 UPCCs, in addition to the second hospital we're taking in Surrey, and more.
Member.
Thank you, Honourable Chair. I have about 20 minutes left. I want to provide my colleague with 5 minutes of that time. I'll have him go next. But I just want to put the minister on notice. Maybe we can get the answer to these questions while we're waiting here. And then I'll have my colleague from West Side ask his question. I want to, and obviously the minister knows this well, the issue of diabetes. We know that British Columbia will spend about $583 million on direct healthcare costs for treating diabetes and complications. The framework for diabetes in Canada has a policy roadmap that would create an action plan. So I'm wondering if if the minister and his government are looking at investing in a comprehensive provincial diabetes strategy, so that in British Columbia we can improve prevention of type 2, screening, treatment, and health outcomes for the province. That's my first question related to diabetes, but I'd like to cede the floor to my colleague for a moment.
Recognizing the member for Kelowna West.
Thanks very much, Madam Chair. Minister, I just had a particularly anxious individual whose wife was diagnosed in December, or discovered that she had a lump, and had a mammography that confirmed that she needed a biopsy. And of course, going through this process, it's moving along at a couple of weeks at a time. Anyways, they discovered that after the pathopathology was completed, the surgeon confirms that the CA cells and lymph nodes needed to be sent to California. And I'm just kind of wondering why we would be sending those results out to outside of the country rather than doing this somewhere in British Columbia.
Minister.
So we'll ask Dr. Kimchi is here. So what I'll do is endeavor to get an answer to the question. I'll also be interested in getting specific details on the case involved from the member because every case is important. And I've on many occasions worked with the member over the years on cases and issues. With respect to diabetes care, I would say that the following, that the actions, we've taken a series of really important actions, historic actions for diabetes care. Previous government on insulin pumps, which I expanded. Access to continuous glucose monitors that has come in. The change on biosimilars, which has saved money and allows us to invest in other responses. Obviously, the second line coverage for Ozempic, which is a big public issue, but for people with type 2 diabetes, having that second line coverage really important. So I have met with Diabetes Canada on this issue because they're pursuing the idea of a roadmap. Not just doing that advocacy, a lot of advocacy with the federal government to ensure that insulin was included in their National Pharmacare program. I think that'll be exciting. We don't have an opportunity to talk about that now, but it may be one of the questions the member wants to put on the record because we have some updates on what we see as the process there. So I appreciate the advocacy on behalf of Diabetes Canada. I met with them specifically on this issue. Give a lot of thought to diabetes because I think how we treat diabetes is an example and really an example of how we treat all chronic diseases, including lots of lessons for chronic diseases such as addictions. So I do think that it's important to update our plans and to work with agencies like Diabetes Canada, but also others who are involved. There's a group called Young and T1, which the health critic may have met with, who are young activists who have their own demands and needs and views, and they were particularly strong advocates for continuous glucose monitors. So I appreciate the member's advocacy, and we're very involved in that question. And for the member for Kelowna, we'll have an answer in a few minutes, and I'll give that as I'm working on the other things.
Recognizing the member for Prince George Belmont.
Madam Chair, I wanted to just ask one additional question about diabetes, and I appreciate the minister meeting with Diabetes Canada. I think they did a great job of outlining, the issue, looking at that framework across the country and a roadmap for action. I thought it was really well done. I guess I wanted to ask also, and the minister correctly describes progress being made on continuous glucose monitors and insulin pumps, but the coverage in British Columbia has not yet covered or provided British Columbians with access to automated insulin delivery system. The automated insulin delivery system. So every other province does cover a pump that is compatible with one of the CGMs that they cover, but BC does not. In fact, there's actually a solution to date has been a DIY hack, something that's considered an absolute necessity, but is certainly not recommended by Health Canada. So many families with children who have type 1 diabetes would like to see coverage provided for the AID technology as a whole package. Can the minister just provide me with a sense of whether he's aware of that issue, whether he's considering that, and looking at aligning our coverage in British Columbia with other jurisdictions?
Minister.
So with respect to my friend from Kelowna, the reason we would go to California on a particular genetic test is we think there's a test that's helpful in a case that we don't do here, and then we find a place to get it done. And that's the reason something would be sent to California. It might be something we don't do generally here. The doctors in question felt needed to be done, and so the results were sent to California and back. And that's the reason we would do that. And certainly I'd be happy to follow up with the case with the member as well. But that's the reason you would do that. If for some reason there was a test that was unusual that we don't do here, then and they can do it in California, we want to get it done for people, and that's the reason why that would happen. Yes, about the issues. I hear about all insulin delivery systems because I use them, and the fact that I still use a syringe and vial should not disturb anybody. I'm at some point I'll learn more in my 60s about how to take care of my diabetes. But yes, I have heard about that. And what we've done is consistently expanded. So that it was initially just the Dexcom, and then we've expanded access to insulin pumps, and to CGM. And this is, as everywhere else, there's always improvements in technology that we have to read. I think our coverage has been Canada leading, but I understand, particularly, I'd say to the member, parents of children living with diabetes who have particular interests and concerns. They're the ones who are often leading these questions. And I think the existence of CGM, for example, is really important for families who often have children who test too many times for diabetes, and the parents don't know how their children's doing at 3 in the morning, and they want to wake them up, and all the things that come with that. So the advent of CGM has been incredibly valuable, and and even though I don't use a CGM myself, and didn't take advantage of that offer, at least not yet. Haven't seen my endocrinologist in a little while. Nonetheless, certainly we've added technology, insulin pump first, then CGM, and these are the next items, and we're absolutely open to reviews of those technologies.
Recognizing the member for Kelowna West.
Thank you, Madam Chair, and through the Minister, thank you for that response. I would really appreciate a follow-up afterwards, just so that for the patients' concerns that they're addressed, because I'm sure that as many or all, they're very anxious.
Minister.
And what I would ask the member to do is just to, get me the MSP number and other things, and I'll ask Dr. Chi to review the case.
Member for Prince George Valemount.
Thank you, Madam Chair, and thank you to my colleague and the Minister for taking a look at that important file for my colleague. I just want to end my time in the next 12 minutes with some things the Minister knows that I care about deeply. I know he does as well. I would not feel like we've had estimates completely done if I didn't ask about ALS and the support for Project Hope. I know that there is a big day coming for ALS this week, which is something I think the Minister and I would agree to share and celebrate. But we do know is there is additional critical fundraising that needs to take place. The ALS Society of BC has signed an MOU with UBC to raise $20 million. I'm just hoping that the Minister will continue to provide funding support to the ALS Society. We've made progress. There's more work to be done. And I'm just hopeful the Minister will have good news for the ALS Society of BC in a continuing effort to ensure we have important clinical trials research. Obviously, we're very thrilled to have recruited Dr. Eric Pioro. It's a very significant step. So maybe the Minister could just give me a very quick response to any future plans for support for ALS.
Minister.
Look forward to being with the member. We're both going to be there on Friday, I think, at UBC to welcome Dr. Pioro, who's leading Project Hope there. In 2020 and 2021-22, we provided a total of $5 million to support Project Hope, and we're certainly absolutely open to that. Just say there won't be an announcement on Friday. We're celebrating Dr. Pioro there, so that won't be. People won't be anticipating an announcement of more, but I think that level of commitment, which I know the member shares, is something that we've spoken about, not just in the House, but outside the House, about that support. My support for the work of Wendy Toyer, of the whole team at the ALS Society is there, and I look forward to speaking on that and celebrating that with the honourable member on Friday.
Member.
Thank you to the Minister for that. I too want to recognize the incredible work of Wendy Toyer. Both the Minister and I have had the opportunity to work with her in a constructive way. I've done many ALS walks with her, and being lobbied all the way around the 5K walk. And it worked. It actually did work. So congratulations to Wendy for the exceptional job she did. She's going to be missed, but she made an incredible difference. Very quickly, I would like to ask a question about laryngectomies. People who suffer from cancer or injuries affecting their throat are often forced to undergo a total laryngectomy, and can imagine what that would be like, the removal of your voice box. And British Columbians who are known as laryngectomies rely on multiple medical devices to be able to speak and protect their health. These devices include voice prostheses, heat and moisture exchangers, adhesives to restore the ability to verbally communicate. And when you combine the use of those three devices, it can really improve health outcomes and the quality of life for laryngectomies, reducing hospitalization rates. Ontario, Alberta, Saskatchewan, and Quebec all have some level of coverage for these devices. British Columbia does not. I'm asking the minister to consider how he might look at closing that gap in British Columbia.
Minister.
On this issue, members of our pharmacare team, and behind me is Mitch Manio, who's outstanding Assistant Deputy Minister, have met with the Laryngectomy Association of BC, the LABC, on a number of occasions. We've also met beyond that with speech-language pathologists as well on the issue. It's an issue that's under active consideration.
Member.
I am very grateful to hear that. I had a very powerful meeting with a number of people who just are inspiring with their resilience and their efforts to change this in British Columbia. So I'm very relieved, I know they will be, to hear the minister is considering that. I'd like to also speak on behalf of the Lymphedema Association. Had an unbelievable awareness session. Obviously, lymphedema, when you have lymphedema, compression garments, lymph drainage therapy can be very expensive, and costs run from $200 to $9,000. I think the minister may be aware that I did a 2-minute statement on this in the legislature after meeting with people who were unbelievably inspiring. And so I wanted to raise the issue that the Lymphedema Association submitted an application to Pharmacare in June of 2021, and we're now in June 2024. I'm wondering if the minister could just give me and the members and the people of British Columbia who have lymphedema some sense of hope as to whether or not funding will be provided.
Minister.
So as I understand it, we do cover lymphedema sleeves in BC. I'll certainly engage with the group as well as the member about issues that they'd like to see resolved. And again, the member will know, look forward, and I'll ask especially our pharmacare team led by Mitch Monio to reach out, not to wait for their request on this issue, and so that we'll definitely follow up, and I'll follow up with the honourable member.
Member.
Thank you, Honourable Chair. Yes, and I think that there are a number of specific questions, so I think if there would be a willingness on the minister's part to have staff reach out to talk about what the gaps are, because they have to be custom made for people. And I know that in Prince George, for example, one of the things that the Spirit of the North, Spirit Day, the lymphedema group there in Prince George actually has raised thousands of dollars to provide assistance to people for compression garments. And that is something that we should actually be looking at provincially to make sure that as many people as possible get the support that they need. I have one final question, but I'm going to give my colleague from Kootenay East. Yes. The minister actually even knows what my question is going to be, but I'm going to ask my colleague from Kootenay East to quickly ask his final question.
Recognizing the member for Kootenay East.
Thank you, Chair. Thanks for the time. Just a quick update. I know we went through this a couple of years ago on Parkinson's and deep brain stimulation, and I believe it was Dr. Honey who was the head specialist in the province, and he needed some help. We had only one in the province. I think Alberta had 3, and I know there was a push to get at least another 2. Just maybe an update on that, where we are.
Recognizing the member for Prince George Valemount.
Well, thank you. And the minister already anticipated the question. He knows how important this is to me personally, but also to the people of British Columbia. But before I ask my final question, I want to express my gratitude to the staff from the Ministry of Health. These questions are never meant to be critical or, I know firsthand how hard the people in the ministry work. I have significant regard for the Deputy Minister who works tirelessly as the ADM and everyone does in the ministry. So I want to express my gratitude and also to the Minister for his willingness to spend hours answering these questions in a respectful way and the commitments he's made to follow up with information. Both of us want the same thing, a healthcare system that serves British Columbians. We want to close some of the gaps and make sure that we have the care that people need. So I just wanted to end my time of questions with, I will, in this session, once again, table a private member's bill looking at the availability for for AEDs to be placed in public spaces. We know that the quicker that a person has a heart episode, if you use an AED in combination with CPR, their chances of survival are significantly improved. It seems like such a simple thing to say yes to, and yet here I am. It's been years asking. So I would just like the Minister to know that it still remains a priority for me, many British Columbians. We need to have more AEDs in public spaces, and I'm hopeful that the Minister will continue to consider not only my private members' bills, but a way that we could expand and extend the use of those in public spaces.
Minister.
So thank you. With respect to deep brain stimulation, it's obviously continues to be an important project, and what we've done is significantly increase the number. So in 2018-19, there were 31 procedures and 63 battery replacements, which obviously are important. And we've led it up to between 68 and 72 the last 4 years. And that's had in terms of new primary insertions, in the last couple of years, about the same number of battery replacements, because they're based on procedures that occurred some time ago, and the battery replacement follows that. So that's just consistent work. What we have allowed is for the project we have added is people capable of doing battery replacement, which is important, that have freed up Dr. Honey to do more work, and we're still doing the work in terms of the recruitment work. But the key in the initial stages was OR time. And so the overall effect on median wait times, the median wait time in 2018-19 was 42.7. The median wait time in P10, which is the 10th period of 23-24, was 7.9 weeks. So that's significant improvement, and that's just pure effort by everybody involved, and the time made available. And I know members on my side advocated for that. I know members such as the member advocated as well. And so people gave voice to those concerns, and that's progress, and we got more to do. We've got to solidify that process, but it's excellent. With respect to AED, last year when we talked about this, I think, or maybe more recently than that, we talked about doing a provincial pilot. And I don't want to give suggestions to the legislative agenda of the opposition, but I think we're at the point of recommending specific communities for the pilot that would see the provisions that are part of the members' bill in place in places, and then be able to show proof of concept. it won't be a surprise that one of those places, from our perspective, should be Prince George. I know that the member met with the Deputy Minister of Health on this question. There's some other communities that we would, that we think would be greatly enhanced by added AED capability in a pilot project like that. So it may be that we can, if it works for the member, coordinate her introduction of that legislation with the work that we've done together on a pilot program that would show the proof of concept, show the difference it would make in community. And if we can do that, I believe that's something we're ready to do in the next couple of weeks, and that would be some important progress. I'll just say finally, we've done the estimates a few times together. I'm not going to count how many times that is, because it's a few times, and I know that the member hopes that this is the last time she'll be doing estimates on the opposition side. And I did a lot of health estimates on the other side as well, as my esteemed Deputy Minister will recall, and others. And I just want to thank the member. This is, I think, a useful exchange for people. We have moments when we have the legitimate partisan debate, and I think there's room for that. There's also room to make progress and do work that we have done on a whole bunch of issues the member and I have had over time. I look forward to getting to Prince George soon, and that'll be a big day for the community and a big day for all of that, all of us together and in our sort of collective efforts as legislature. I want to thank her. I want to thank all the members of the opposition. I think we try in health estimates to use the time usefully, of the BC United opposition, I should say, participated in this debate. I think we use the time usefully, and members raise issues that are really important. The member for Kootenay East has raised the DBS issue with me a number of times. And you see that built over time, people's commitment to issues that I know members of the opposition have. I want to thank all of our team, but in particular Deputy Minister Steve Brown, new Deputy Minister Jonathan Dubé. These estimates have been going on long enough that people are getting promoted around here, which is pretty good. Congratulations to Jonathan, to Christy Anderson, who I called Kirsty a little while ago. I apologize for that. And our outstanding ADM, our whole team that's here, that's represented by all of our folks here who do exceptional work. Our folks in the Ministry of Health are just fundamentally committed, and I think that Steve Brown sets the tone for that in the way that he treats people, all people on a daily basis, and that sets the tone for the entire Ministry of Health and has. And I want to pay particular tribute to Steve, since he's been Deputy Minister of Health for 11 years, and he's had to work with Terry Lake and me, and so there you go. We'll just reflect on that, and the chair knows what I'm talking about. So I want to thank the members of the official opposition, the BC United opposition, and I look forward to the questions from the member for the Green Party.
Member.
Thank you to the Minister. Thank you to my colleague. I'm sure if there's any follow-up related to the question that he raised. And now I'm happy to hand off the time. She's been very patient, waiting for her turn, my friend and the leader of the Green Party. It is now her turn to speak to the Minister.
Recognizing the leader of the third party.
Thank you, Chair, and thanks to the critic for the official opposition. Happy to have some time to ask the Minister some questions. I think I want to start with a topic that's been canvassed a lot in question period, and that's the issue around consumption of substances in healthcare settings. The Minister a couple of weeks ago indicated that there would be supervised consumption sites in healthcare settings in hospitals. But now there seems to be some shift in that position. So I guess the starting place is, does the Minister see supervised consumption sites as part of healthcare infrastructure?
Minister.
We have supervised consumption sites across British Columbia, and the evidence has been very strong as to their success. And one of the challenges in many communities, let's give the example of Dawson Creek, for I won't say what reason, but where there's a discussion, right? The community, a lot of people in the community wanted the supervised consumption site to be on the hospital ground in that case. Met with the mayor and talked about that, which was away from where the community of people who needed that site, what lived. And so there are issues in different places about supervised consumption sites and where they should be located. The question that came up in the media was, will there be one required at every hospital? The answer is no. The answer has always been no. But I would say on the issue of supervised consumption is changing just as it's changed at different times in the past by the nature of what illicit drugs people are using, that we've seen a very significant move from injectables, drugs, and to use the term there, other terms of smoking drugs, and that is change in the human behavior of the people who present in hospitals. And that is a challenge we have to adjust to, just as 10 or 12 years ago, or more now, when I was health critic for the official opposition, the health system had to adjust to the onset of crystal meth really profoundly affecting communities and people who used healthcare services. So I've answered this question a number of times before, but I'll answer it again. The answer is not in every hospital. We do have one supervised consumption site in a hospital building, which is St. Paul's. We have others on hospital sites, and I'd be happy to share all the detailed information about that with the member. With respect to the task force and actions that we're taking, I think you can expect some action soon to support patients and workers on site to support them on this issue. So this isn't going to be a task force where we're going to be reporting in 6 months. It's going to be weeks and not months.
Member.
Thank you, Madam Chair, and thanks to the Minister. If I could just request that he speak a little bit more into his microphone. Thank you. That would be his old lady ears here. I just want to explore this a little bit more because the concerns that are being raised are important and legitimate concerns. Nurses are speaking about conditions in their workplace that are unsafe. We've also heard from nurses on this front, and you know, we need to be in a recognition that all British Columbians have a right to access healthcare. And so there is some tension that's being explored in different ways in question period, but I think it's an important conversation for the public to hear about what immediate and effective steps can be taken in healthcare settings to ensure both protection for people providing healthcare and protection for people who need to seek healthcare. For example, are there prescribed therapies available to people who are seeking healthcare who are suffering from substance use addiction? And is that an avenue that can be implemented effectively to address these concerns and these conditions? And I would expect, given the scope of the illicit drug poisoning crisis that we have in this province, which is province-wide, that this isn't an issue that's restricted to one particular healthcare facility or one hospital. And so what does the minister and the ministry see as the role to address this? I understand that there's a task force, but this is a day-to-day situation that does, I think, need a response that takes into account the need to provide both protection for workers and protection for people seeking health care.
Minister.
I agree with that. And I think this is part of the work and all. If I'm not facing the honourable member, that might make it better, maybe more important that she hears me than sees me. I'd say, first of all, that issues of occupational health and safety for nurses and for others, right? Because it's the same for health sciences professionals, it's the same for healthcare workers, it's the same for doctors, ambulance paramedics, and others, are a key part of the Health Human Resources Plan and the work we're doing in particular with healthcare unions. So one of those issues is workplace violence, which is sometimes linked to this issue, although it's not always the same issue. There are specific elements around the safety of nurses and others in the healthcare setting. And it's why we worked with nurses and the hospital employee union to recreate an occupational health and safety agency called Switch BC, which was eliminated under the previous government by the leader of the opposition when he was Minister of Health, as it would be, and that was a loss. And so we have an organization that was in charge of both approving the training program, not doing the training, but approving the training program, and then assessing the 320 relational security officers that have been hired and at 26 sites in the healthcare system. That was an example of something that came from our consultation with healthcare workers. It's a new security model that focuses on both the number of security staff and their quality. We've also done significant work on issues like counseling and virtual mental health supports and direct funding of nurses' mental health and wellness supports and direct funding for the HU and the HSA and others as part of $100 million in funding from the Ministry of Health to expand nurse recruitment, retention, and wellness supports. That means mental health supports for nurses who hit a ceiling in their existing benefits plan, for example, hardship support for members who have exhausted, for when a member has exhausted employment insurance, long-term disability, and other programs, and hardship support for students in financial crisis. Also specific actions around exposure to illicit substances in hospitals, and the work that we're doing immediately with task force to ensure that while the circumstances can be different in different hospitals, that the rules are set across the board, and we work with patients and others to ensure that that people are safe. The members identified the key challenge. The hospital is a place we all come together, right? What people in hospitals share are the fact that they're sufficiently ill to be admitted to an acute care hospital. And today, there are about 10,125 of them today who are that sick. And they come from all walks of life, disproportionately those with addiction issues, disproportionately with those who have lower, what we call the social determinants of health, who are facing poor social determinants of health. But nonetheless, a whole group of people. They're all coming together. They're not together everywhere. They're together in the hospital, joined together by their need for care and then the care provided for people. So we have to ensure that if you're in hospital, you've, for whatever reason, don't have addiction issues, that you're not facing secondhand smoke or something that's a problem in your room, because that doesn't help you get better, and that's not what we expect. And so those people have to be, that group of people have to be in our mind's eye. But also people with addictions. Well, part of the reason we have policies to engage with people with addictions is the same reason we would for any other chronic condition, right? If I were admitted to a hospital with diabetes, the nurses would need to know I have diabetes. And similarly, if a person with addictions we have to engage with them about their addictions. That is the only way that people who need care will come to the hospital if they're severely addicted. And their circumstances are extremely challenging. So we have to do that part of it, and we have to ensure workers are safe. And so that's a host of measures. And I won't take up all the time, but it's a longer answer, and we can get into some of the details of it. So those are the elements, though. And when we move from primarily injection to primarily inhalant, that has an impact too, just as previous changes in the drug supply have had profound effects on patients in the hospital. I mean, people often refer to safe consumption sites as safe injection sites, but when you have a market that's disproportionately now inhalants, that is a much different and more challenging proposition to support people in the community and protect workers who are working in such sites in the community from the impacts of inhalants.
Member.
Thank you, Mr. Chair. Welcome to Chair. On that front, can the Minister just let us know how many safe consumption sites are there in the province right now that can support inhalation? And how many total?
Minister.
What we'll do is just get the specific answer, and then I'll get back, and then if the member has a line of questioning, she can come back to that. I just don't want to delay her time.
Member.
Okay, I'll carry on a little bit on the same theme, but around the issue of caring for patients who have both mental health issues and addictions. And that we have been hearing from constituents that people have been confronted with, you have to solve one, you can't come with both, that they can't access treatment for mental health needs while struggling with addictions. And I guess the question for the minister is, does he think that there are sufficient supports for people who are struggling with the intersection of both mental health issues and addictions?
Minister.
Well, I think an approach that sees mental health and addictions as comorbidity is the direction we've gone in. And remember, asked if the services are at the level I'd like to see. Obviously, no, we're building out those services, and this has been the subject of, I'm sure, her exchanges with the Minister of Mental Health and Addictions. So I won't belabor that point. But these are comorbidities. I just recommend to the member, if she gets the opportunity in Vancouver. One of the projects that we funded in the Ministry of Health a number of years ago was Hope to Health, which is Dr. Julio Montañer's work that he does in the downtown east side. He's most known, of course, for his work on HIV/AIDS, with significant work which does exactly that kind of treatment, and that we're obviously looking at building out as well. And so I would encourage the member to do that. We would certainly arrange that. I know Dr. Montañer would be delighted to do that, to talk in detail about what can be done. But we of course see those as comorbidities, and that doesn't mean that you can't have a mental health issue and require treatment without an addiction issue, or vice versa. But clearly, overwhelmingly, these are comorbidities for people.
Member. Sorry, getting lost here.
Thank you, Mr.
Member.
Chair. It's the second time I've gotten that promotion today, actually. So I don't know, third time's a charm. Demotion. I just want to continue on this a little bit longer, given the scale of the crises we're seeing with the toxicity of the illicit supply. The minister talked about the socioeconomic conditions, about the impact of the burden that poverty is having on people, that impacts their health, it impacts their mental health. These intersecting forces are really contributing to very difficult conditions for people, and I'm afraid to say a growing political rhetoric that I think is also harmful to people. And can the minister just speak to where he thinks the response to these crises are, the toxic drug supply crisis, the growing mental health crisis that we're seeing in the province, and a growing burden of poverty, homelessness. has the health system scaled its response to this in a way that is going to meet the needs of the people? And I would say it hasn't, but how much further does the minister think the health system needs to go to be able to meet these needs? And what are the pieces that are currently lacking? For example, access to mental health care, the proposal that we've been making for several years about incorporating psychologists into MSP, 6 visits a year, and creating more of a accessible, affordable mental health care network, regulating counselors and other mental health care providers. But I'd just be interested in hearing from the minister the scale that he would imagine is needed to respond to this and where we're at in that level of response.
Minister.
Yeah, I think, and obviously these estimates are about healthcare, but we're all affected by our personal circumstances, I think. What I can say in a general sense, if you look, say, at someone with diabetes who is on disability compared to someone with diabetes like me who has a strong supportive family and a good job and work people around them support them, that's a massive difference. So when I look at the diabetes issue, I've got to look at it in 2 ways. I believe that we need to enhance coverage for continuous glucose monitors. I think we have to, and we've done that for insulin pumps. We need to provide access to things like Ozempic, which are important new discoveries as a second-line coverage. All of those are very expensive. But for people with diabetes, I think you also have to address issues of what we call the social determinants of health, which is a fancy way of dealing with inequality. And since that's the major focus for me of politics, which is reducing inequality, the reason that I'm in politics, the reason I believe in that, you need to take actions that address those questions as well. So that means housing is healthcare. That means childcare is healthcare. That means reducing poverty is healthcare, right? And that one of my challenges as Minister of Health, we have this debate about how much we spend on health, and in 2008, people said, oh, it's 42% of the budget, and it's going to be 70%. Well, it's still about 40% of the budget. It's a bigger budget. But one of the reasons why we need to take steps to ensure that we spend money prudently in health is to ensure space for other people. We have to dramatically provide care for people with addictions, but we also have to provide the education and support for young people so that, the next generation will have fewer addictions. And so I see the healthcare and the health of people in a society as deeply rooted in those questions. So there are things we need to do in healthcare, and I could provide a nice answer to the question, but I think fundamentally the issue of housing, and if someone is discharged from hospital, they have a crisis with their diabetes, and they're not going home to safe housing, then they're going back to hospital, right? And so the answer to that problem isn't a better CGM, although I support that, and we got to balance these things off against each other. The answer to that is housing, right? And so, you know, sometimes I think one of the challenges for the healthcare system, we have 575,000 more people in 3 years to MSP. Can you believe it? Like 10 years ago, the 3-year average would have been about 130,000. So we got to build out to meet the population demand of the system. But we can't just do that. I would argue that all of those investments and other things and their impacts on human health have to be priority consideration against healthcare spending all the time. And that's what I try and do as minister, as an advocate, because that's what I believe is important. And the reason Medicare is important is because it reduced inequality. And it reduced inequality. It's one of the many reasons it's important. It's important if you have a broken leg and you need care. It's important for all kinds of reasons. But that's a critical reason for its fundamental importance in Canadian life and why it's a fundamental core of my belief, that debate. But Medicare isn't the only health question. So is housing. So is education. So is training. So is advanced education. So are labor laws for people. So that's a long answer, and I'll leave it to them.
Member.
Thank you, Chair. And I think it is an important context for looking at health, and I think I would agree with the Minister. I would say that these are all aspects of, in a way, of public health, of keeping people healthy, keeping people out of the acute healthcare system by ensuring that people are healthy. But we are seeing a lot of people who are not staying healthy, and the Minister knows it's happened. I'd expect in many of our constituencies where people are being discharged to their car. We've had constituents reach out to us about, for example, a patient discharged after an amputation to her car. So that is happening. And it's happening far more frequently than I think any of us would ever expect or want to tolerate, but it is happening. On the funding, I'm curious around ratios in healthcare funding. I'm wondering if the Minister and his staff are able to provide a ratio in the healthcare system, and probably, I expect maybe not off the top of their heads, but possibly, the ratio of frontline healthcare workers to behind the scenes, managers, coordinators, project, all the behind the scenes, not the front line. So in the healthcare spending budget of that particular kind of spending, what is the ratio between the front line and the back line, I guess we will call it?
Minister.
Thank you. And just for people who might be watching, the leader of the Green Party, the third party, has provided some notice of the areas she's interested in. So when I get up right away, it's not because I have this answer necessarily at my fingertips, but she did that, and I'm very appreciative of that. Just on the issue of corporate services expenses, the CIHI keeps data on this. It compares us nationally to other jurisdictions. Our corporate expense ratio is at 3.3%, which is the third lowest in Canada, which is good. Lowest being good. The average is 4.4%. So that's, we're 33% below the Canadian average, or is it 25% below? It's below. In terms of the people who work as managers and non-managers in the healthcare system, just to give a sense of the specific answer to the question. In 2023, which was last year, this isn't quite up to date, 225,000 people were forecast to work in BC's healthcare system. Approximately 6,738 of those from that forecast are classified as management. So that's approximately 3% management and 97% non-management, which is an important ratio. And of course, the significant increases that have taken place are in recent years in terms of healthcare workers are for frontline workers. The health authority that has the highest level of administration is inevitably the Northern Health Authority. In fairness, they have to provide care through a wide geographic area. I think it would be understandable that would require more management responsibility than other health authorities. But that's where we are. We're one of the lowest administrative costs in the country, and that's roughly where the proportion of management, and many of whom, of course, are nurses and doctors and others, but management to workers is.
Member.
Thanks. And yeah, we did provide some questions ahead of time, and one of them was, can the Minister break down for us the amount that's being spent per agency nurse compared to the amount for public nurse?
Minister.
So this will give a sense, and I provided some detailed information in the official opposition that's more detailed on this question, which I'll also endeavor to provide to the member on just by health authority and other issues that we're providing. Agency hours represent 2.9% of total productive hours in the health system. That's up from the past, but it just puts it in context. 97.1% is the rest of it, which is non-agency. We have a standard pricing arrangement for agency staffing in the system. We put a moratorium on new agency contracts the year before last, so there were 17. We did add one in Prince George since then, so there are now 18 contracts. The standard pricing agreement is effective until May 31st, 2024, when the new standard provincial agency contract will come into effect. So those are a few facts for the member. In a general sense, under health authority employed nurses make between $41 and $68.10 per hour, plus benefits and access to premiums and other incentives, which are significant in the new Nurses Bargaining Association collective agreement. It was the main focus of that agreement to make it even better deal for permanent staff, to support longstanding nurses, and a lot of, I think the program put in place, and then the additional actions we've had with the nurse ratios proposal is making a significant difference. Health authorities, just in that context, pay approximately $70 per hour for agency staffing, but these costs include travel, agency costs, and inevitably profits and other expenses. So that's the rough difference between the two.
Member.
Thank you, Chair. Can the Minister just let me know how many vacant nursing positions there are right now in the province?
Minister.
So and I'll provide the member with information which have also provided the official number of opposition about hirings in the last year, which are significant. This is our best year for hiring nurses ever in terms of positions vacant. There are the job vacancy and wage survey estimates 5,463 nursing vacancies in BC. Of course, we're adding nursing positions all the time, so we're not in some ways helping ourselves with that. And as of December 31st, 2023, there were approximately 4,835 vacancies in health authorities plus Providence Healthcare with position control numbers, 2,967 active job postings in health authority without position control. That would make approximately 7,800 vacant nursing positions.
Member.
Thank you. Thank you to the Minister for those numbers. One of the issues that's been brought to us, I'm not sure if it was canvassed already, but for nurses, particularly with urban hospitals like Royal Jubilee, one of the challenges the nurses have is a lack of parking. So they can't find parking on site, have to use off-site parking, often at a city parking meter, have to face with trying to move their cars partway through their shift or get parking tickets. Has there been conversation around a solution akin to what I understand MLAs used to have, which was a little sticker that let them park at any city parking meter. Where we don't have that anymore, probably a good thing. But would there be a consideration of that kind of solution for nurses in urban areas that are unable to get secure parking where they work and are struggling to access parking?
Minister.
This is a two-part issue. In some cases, it's the issue of parking stalls and having adequate number of, so you see significant projects with very significant increase in parking stalls. Also, quite a bit of work done in a lot of health authorities with shuttle buses and support, for example, those linked to SkyTrain. It's a huge advantage for nurses that the new St. Paul's is on the SkyTrain route, whereas the old St. Paul's is not. And that advantage is felt in probably 5 hours a week of reduced transportation costs. So a lot of that's about that transportation. We've got to do all of that. With respect to parking, I mean, one of the challenges we've had, and one of the reasons there's a real lobby for free parking at hospitals in BC, as a member will know, for everybody. And one of the challenges we faced, we did provide that at some points in the pandemic when there were fewer people coming to the hospital site. We did note that that tended to make some of our hospitals, make it impossible to find parking in some of our hospitals. So that was an issue. We have frozen parking rates across health authorities, and we have since 2017. So it's, in general, that's the case. What we've done, this is an issue that's raised by nurses, but what we've done is to put in place, I think, the best collective agreement for nurses in the country, including all the work we're doing with nurses on nurse ratios, but also redesign wage schedules, hourly service increments to help retain mid and late career nurses, new hourly shift premiums, increased hourly shift premiums, for example, for evenings, for nights, for weekends, for what are called super shifts, for on-call premiums, for in-charge premiums, an increase in the business allowance for community-based nurses, and a commitment that employers have followed through on to pay for 100% of college fees for nurses and other health professionals. So those are significant improvements in the collective agreement. I know that the parking issue for me is really one of access. We want to make sure that people are safe and have access, especially when they're working 3 to 11 and 11 to 7. Those shifts, we want to make sure people are safe on site. So there's a lot of focus on making sure there's adequate parking in place. And we've been addressing the issues of nurse compensation through the collective bargaining process with the BCNU.
Member.
Thank you, Chair. The Minister's talked a fair bit in question period about hospital protection officers. Can he just provide a list of where they've been hired? If the outcomes aren't improving, what are the next steps that the Minister sees?
Minister.
The initial 26 sites were selected in consultation with the BCNU and health authorities. They are Abbotsford Regional, and what I'll do is provide the list to the members as well. But Abbotsford, Burnaby, Chilliwack, Delta, Langley, Peace Arch, Royal Columbian Surrey Memorial, that's Fraser Health, Mount St. Joseph's and St. Paul's, that's Providence, Lionsgate, Richmond, Vancouver General, that's Vancouver, BC Women's and Children's, that's PHSA, Cowichan Lodge, Saanich Peninsula Hospital, that's Island Health, because Island Health already had the model in place, so those were 2 additions. Interior Health was Caribou Memorial, East Kootenay Regional, Kelowna General, Kootenay Boundary Regional, Penticton Regional, Royal Inland, Vernon Jubilee, Mills Memorial, and Northern Health, which is the current hospital in Terrace. There'll be a new one soon. Prince Rupert Regional, and the University Hospital, which is in Prince George. We're looking at adding other sites.
Member.
Thank you, Chair. I want to move on to primary care for people. Is there data on how many people are still not attached to a primary care provider right now?
Minister.
So in Canada, the principal way we get this information is used when people use the number in the House. It's the Canadian Community Health Survey. And we went from about 300,000 people without a family doctor, in BC, according to the Canadian Community Health Survey, to about 910,000 when I became Minister of Health. Most recent survey shows that had been reduced with a rising population to 884. But that's the Canadian Community Health Survey. So that's a survey that's done, that's what often is used in the public debate about how many people need a family doctor. What we're doing and transforming, the reason why this is an important part of transforming the system, is create the Health Connect registry. In other words, actual people. So the survey doesn't help you if you need a family doctor, it just describes the problem. The Health Connect registry.
Sorry, members, could we have some quiet in the chamber, please? Thank you.
So we have, so I'll provide that data over 20 years to the member, which we have from the Canadian Community Health Survey. But our Health Connect registry numbers are currently, we have on the registry 316,255 people who have sought attachment. 396,000 people who have sought attachment. 316 of those have not yet been attached, 316,255. We've attached in the neighborhood of 69,000 on that list. On the neighborhood of 71,000 on that list. Sorry, I was counting the wrong number. And so that's the progress on that registry. In addition to that, we've attached in the hundreds of thousands people with doctors, new to practice contracts and others, and I have all of that detail, which I'll provide to the honourable member. What it says is that there's a lot of people who need a family doctor who want one. And what I didn't like about the Canadian Community Health Survey, even though the numbers, you could argue, were good for the government in a way, they didn't really mean anything to people. People are now joining the Health Connect registry, saying they want a family doctor, and we have a system in place and spaces for them in the hundreds of thousands at family doctors and nurse practitioners now. And that's a meaningful system that you can judge month to month, day to day, month to month, week to week, month to month from now on. And those are the numbers in that. But I'll share all of the numbers with the honourable member.
Member.
Thank you, Chair. And for the people who currently don't have a family physician, what is being done to improve access for them to the kind of preventative care that is very hard to get without a family physician? So access to getting tests or getting test results or getting referred to a specialist. What's being done in the meantime while this enormous number of people who don't have family physicians are currently not attached? How are they getting access to the kind of primary and preventative care they need?
Minister.
So just as an example, I mean, the key thing is to get people access to a family doctor and nurse practitioner through team-based care. We've added the 1,800 FTEs to primary care networks, which are defined and needs are defined by the community. I'll just give the member an example, though, of what I mean and why I hope that she will encourage people to sign up for the Health Connect registry. And I know she has been. It's really important. Here's the reason. Cowichan Valley. PCN community in Cowichan Valley. On our list, 6,625 people active, 2,353 attached, which is significant, and another 38 pending. And I'll provide that to the member. But just as an example, we have 22 providers in Cowichan Valley PCM who are able to take patients now. And that represents 1,848 spaces. So that's real progress for a lot of people, right, in the interim. And so that matching process is what we announced and talked about a couple of weeks ago, because it's a bit laborious. In Canada, we don't assign you a family doctor because it doesn't work to do that. That's not the way the system has worked here. But there are opportunities. We want to really encourage people to do that, and that's fundamental to what we're doing. In addition to that, is the building out in many communities of urgent and primary care centers, which provide team-based care. And we have in the neighborhood, I think, of 480, I should say, FTEs who work for urgent and primary care centers who have provided, I think, 2.7 million visits to people with team-based care, doctors, nurse practitioners, and nurses, which has been an effective process and has a number of different models. So at REACH Community Health Center, we have an urgent and primary care center attached to a community health center, which we're also supporting at REACH, that's one model. Other models include medical arts in Nanaimo, where it's an existing, pretty outstanding team-based care group where we attached it, but we didn't try and create a health authority run one there. In that case, we did it that way. To other communities where it's health authority owned and operated, including the most successful in terms of number of patients in Kelowna. We also have a series of measures to support episodic care and prevention, both through primary care networks and supporting what are sometimes called walk-in clinics, which is an important approach too. We have to provide them with supports as well. They provide some of the same services we're providing with UPCCs in a different way. Finally, we have to regularize the virtual process. We pay for a lot of virtual care in BC, and what we want to do is incorporate that care, particularly in the period when people are waiting for a family doctor, to incorporate that care and make that more available and more organized in the system. Our primary care system tended to be in the fee-for-service. It was just happening out there, and the whole relationship was about patient visits. It wasn't about patients, and it wasn't about physicians. And the change to the LFP model, which has, I think, been an important change, a sea change, if I use that term. It's only been hackneyed since the 16th century. But to make that kind of change has been fundamental, is it connects doctors with patients. And what we found when we reviewed all of the patient records and the information that came in from doctors was a lot of doctors were attached to multiple patients. So we're also working through that process to ensure there's maximum possible access. But members, right, episodic care is important. It's also important for a group of people who may not want attachment to a family doctor, but need care when they need care. You know, and that might be someone you can imagine in their 20s without any health needs, is really healthy, and so they're not wanting an attachment to a particular family doctor. So we've got to meet people where they are, and that's what we're trying to do with the primary care strategy.
Member.
Thank you, Chair. The Minister brought up community health centres, and in Cowichan alone, there's a group of doctors who are trying to put together a community health centre. There's another group that's trying to create a women's community health centre. I know in Souk there's a group that's been working on a community health centre. I've visited a lot of community health centres. They are providing the kind of care that the Minister talks about, team-based care, collaborative, but longitudinal, which is really important. What kind of supports are healthcare providers getting when they are wanting to create a community health center in their community?
Minister.
I think that this is a model that I've really supported as Minister of Health. I believe in. Until that the Rise Community Health Center, which is an offshoot of Collingwood Neighborhood House in my constituency, or supported by Collingwood Neighborhood House, which is a really good example of how it can work well. Because in the case of Collingwood Neighborhood House, we had an existing nonprofit provider which had deep roots in the community, which was able to support that project, which was Rise Community Health. It had been a community health center run by the Health Authority, been shut down in 2013, and we created together a community health center that's attaching patients, especially patients with vulnerabilities. So that's an example, a model of doing that. All of our community health centers were in trouble, the ones that existed. When I became Minister of Health, we've provided lots of sustainment funding over the years for those private bases, including to the association to help them support it. And we just engage with community health centers where they are. Because one of the challenges with public health has been that the Medicare model, the fact that it's seen as, it wasn't encouraged in the past, in the fee-for-service model, it's difficult. The Medicare model, people who are engaged in what we call social capital and community didn't gravitate to that because those services were being provided in a certain way. But we see a lot of communities that want to see them. And the new model and the change in the approach of doctors away from fee-for-service to our new model, I think means that we're going to see more and more community health centers, which used to be kind of a model of private clinic. But community health centers, if you were to talk to the association, are more than that in their engagement to community. So yes, we're hugely supporting the new community health center in Souk, which may be part of the honourable member's life, you know, and has been, and that community, the Western communities and others have been part of that, absolutely in Souk. Just launched one on Bowen Island, believe it or not, which we launched, I was part of that, and I met with the community in 2019 on that. They were affected by COVID-19, but it's really remarkable the work they did. Rutland, which is a community near Kelowna, has a new community health center in the 2023 year. Did some work with a member for Kelowna Lake Country on that. Lake Country as well, which has a community of people in the community that's working on it. We're providing support to that. Some of that is work that they have to do on their side, and all of the other work that we're doing to establish them. In addition to that, there's a whole series of Indigenous-led community health centers. And just to say, we have 5 community health centers in planning right now. We provided 27 million to the 9 that are currently in implementation, which are in addition to the ones that were there before, which we've supported as well. And we're expecting a number more to be launched in this year in communities from Campbell River to Vancouver to Interior Health. But I think the next 2 or 3 years, the increases aren't going to be these kind of increments where we're creating 5 or 10 or 15, but they're going to be much larger because doctors who are at the core of these, they're not just doctors and nurse practitioners, are not as interested in managing and owning the clinic. We've had this discussion before, and they would be interested in nonprofits doing it. It takes a while sometimes to build nonprofit capacity, even with all the support we gave to RISE. It took some time to put it in place. But I think the benefits are exceptional, and I'm a strong supporter and will continue to be.
Member.
Thank you, Chair. I think continuing with this a little bit, that you know, there's and I appreciate the minister's voicing his support for community health centers, for nonprofit community health centers, but at the same time, we're seeing a proliferation of private healthcare delivery in the form of, you know, clinics that are available but for a fee. I was leafing through a magazine a couple months ago, and it was, you know, get all your primary care needs met for this monthly fee. What does the minister have to say about the proliferation, and we saw it with TELUS Health, of healthcare delivery being put behind a private shield of a upfront fee for access to that care?
Minister.
Well, in 2018, we strengthened the Medicare Protection Act, including new protections for patients against extra billing. Those have been changes that had waited really a generation for. In some cases, they've been passed by the legislature in 2003 and 4 and never implemented. Put those in place. In September 2020, we won the Canby case. That's not a small deal, that's a big deal in terms of the public health care system, and that was the work of successive governments, not just this government, successive governments. With respect to TELUS Health, issues were raised. We discussed them in this House around TELUS Health. The Medical Services Commission filed an injunction, and they did that work with TELUS Health, as they are with other organizations that may be practicing in violation of the Medicare Protection Act. In February 2023, filed an injunction application against Harrison Healthcare, and the subject of that is continuing. And so I'm a strong believer in the Medicare Protection Act, strengthen the Medicare Protection Act, but we also have to, and in the very important areas of diagnostic care, we've bought private diagnostic providers. We've purchased private surgical centers. The number of, that doesn't mean we've eliminated health system funded private surgical clinics. There's still some, because we don't want to reduce capacity in these times. We wanted to rank up capacity, but we purchased 2 on Vancouver Island, purchased 1 in Prince George, purchased diagnostic centers, but mostly, when I became Minister of Health, there were more private MRI machines in Metro Vancouver than public ones. And we have dramatically expanded the public system. When you have only 174,000 MRI exams in a province the size of BC, we now have 325,000. You are asking people for a small amount of money to get ahead on wait lists, and we've changed that by improving the public system. It's not just cracking down, it's improving the public system. We've done both.
Member.
Thank you, Chair. Just from the public accounts records, there are 2 companies that I'm just curious about the funds that go to them and what those funds are for. So Maximus BC Health Incorporated, in this 2022-23 got $60 million. And TELUS Health Solutions, $2,561,000. That's separate from all the other TELUS communications and corporation and security and mobility, and they all got different, but in particular, Maximus BC Health, $60 million, and TELUS Health Solutions, $2.559 million. What are those funds going towards?
Minister.
And this was an issue in the legislature in 2006, that essentially services, billing services that had been provided by the Ministry of Health were contracted out to a company called Maximus, which is, and you see all those years later, that contract was put up for a competitive bid. It's now, that bid was won by Pacific Blue Cross, so that number won't exist in future years. Under that contract, it'll be Pacific Blue Cross, which provides that range of services, not direct healthcare services, billing services in the medical services plan. And it's called HIBC, and everyone will be familiar with that. It had been provided directly by the Ministry of Health, and it was contracted out by the previous government some 18 years ago, and that's the Maximus contract, and why the number is so big. I don't know offhand the answer to the TELUS question, but I'll provide it. I just want to get precisely the line we're referring to, and I'll commit to providing the information to the member for tomorrow. So it's not, but we do, TELUS does provide for us a number of services, including MSP-related medical services, some virtual care that is MSP-related, consistent with the Medicare Protection Act. In addition, they provide some home health monitoring services, so it may be that. But if I get the specific line item, I'll give the member an answer in writing tomorrow.
Member.
Thank you, Chair, and thanks to the Minister for that. These are from Public Accounts Consolidated Revenue Fund detailed schedules of payments for this year. Maximus seems to be, and this is outside the realm of health, but they do seem to receive, they meet $22 million from social development poverty reduction, 612 for express and freight, 737 for Canada Employment Services, 50 million for Maximus Canada Services, and then the 60 million for Maximus BC Health. So just to be clear from the Minister's answer, is this the last year that Maximus will be getting? Because in the previous years it was 64 million in 22, 70 million in 2021. Is this the final year of the Maximus contract?
Minister.
Yeah, the services would transition. I mean, I can't speak to the other ministries. Those contracts may continue, but those services have been transitioned to Pacific Blue Cross. And my former colleague from Saanich South, David Cubberley, raised these issues for about 2 years in this House around Maximus in about 2006 and 2007. But those were decisions that were made and had been in place for a long time, and contracts that were in place for a long time. That contract came up. I think it had been extended during COVID when we were extending contracts for a little bit. It was put up for bid. Pacific Blue Cross is now the contractor, so that line will transfer over to Pacific Blue Cross.
Member.
Thank you, Chair. And I think this is my last question, and I hand it off to my colleague from Parksville, Qualicum. Thank you. And this is back to access to primary care, but the rural practice subsidiary agreement, the input we got was that it favors those regions with better transportation options and infrastructure because it relies on distance. It's basically looking at distance, and it doesn't reflect terrain such as mountains or islands and more remote communities. Is there going to be any change to that rural practice subsidiary agreement to take into account the different kinds of terrain which aren't captured simply by distances alone?
Minister.
So the rural practice subsidiary agreement is not just a distance-based agreement. The communities are designated as A, more rural, B or D, less rural, depending on the number of isolation points awarded to a community using the medical isolation point assessment. And here are the factors that are included in determining that assessment: the number of designated specialties available within 70 kilometers, the number of family practitioners within 35 kilometers, community size, distance from a major medical community, Kamloops, Kelowna, Nanaimo, Vancouver, Victoria, Abbotsford, Prince George, etc. Communities only accessible via ferry are allocated a multiplier of 8 times the water distance. Should be of importance to her colleague, I think. The degree of latitude, communities with a latitude of 52 degrees or higher receive additional points towards their total allocation. Specialist center communities with more than 3 designated specialties in their physician supply are awarded points for being considered a specialist center. And location ARC, which is the aerial distance from Vancouver. So those are the elements that make up for that, including the straight distance. And I can share this with the honourable member as well.
Member for Parksville, Qualicum.
Thank you, Chair. I appreciate the Minister making the time here today to answer questions regarding healthcare. It's obviously a paramount issue across the province, but especially in Parksville, Qualicum. I want to start with access to primary care. In our community, we have, and I'll ask for the specific number from the minister, many people on the Health Connect registry waiting for care. This is a list that carried over from an existing list, so we have folks on that list who have been on there for almost 3 years. When I now reach out to the ministry for the updated count as far as where we're at with the Health Connect registry, the minister's staff replied back saying, do an FOI if you want this information. I'm hoping I can get an answer today through the chair to the minister. How many people are on the Health Connect registry in Oceanside, in Nanaimo, and how can my office answer constituents' questions as far as how many people are on both these lists moving forward?
Minister.
With respect to the Health Connect registry, I think this is a really positive evolution, particularly for a community like the honourable members. I know we've discussed this before. With respect to Oceanside, we have active in terms of registered status, 11,337. Attached, about 2,700, which is good, you know. Could be better, like 2,800. That would be better than 2,700. I think the member would agree. And he was asking for Nanaimo as well, I think. The member was asking for Nanaimo, I think, yeah. That number of actives is 13,758. That's active in that community, which is obviously a larger PCN than Oceanside. On the other side of the equation, the member will be interested to know that there are doctors and nurse practitioners taking patients as well. So we encourage people to get on the registry, and we're obviously continuing to take action to make those connections. What's happened, what's changed is in our healthcare system, we never had a list of patients who are attached, and therefore knowing that there was space available under our contract to attach patients, we've now done that as well. And so those are the targets we're setting in those communities, and we're seeing in communities like Nanaimo, like Parksville, like Welcome Beach. In the last week, I've heard from people who have got attached in the last week to a family doctor because the system is starting to work for them. Doesn't mean we don't have a ways to go. But Island Health saw the biggest increase in family doctors, a 21% increase in longitudinal family practice doctors in 9 months, which is astonishing. And now we've got to connect those patients who are asking there to those doctors who have space available. And that was a long process. And it's a long process because we actually have to make the connection and agree to it for an attachment to take place. It's been taking too long, so we've done some things to speed that up, but we're not going to assign, you know, and I don't think it would work to assign. People would just not accept that, so that's the approach we're taking. But those are the numbers, and I'm happy to give them to the member.
Member.
Thank you, Chair. And recognizing time, I'll try to go quickly. Just the second part of that question is, how can my constituency office get updated numbers? We regularly have people asking us. The last time we asked the ministry for the updated count, we were told to do an FOI. I don't think that's appropriate. We've got members of the community that are asking for this. It's not political. Just wondering how we can get that information on a timely basis moving forward.
Minister.
Just got it for April 17th, so that's pretty timely. And we can continue to offer that. But April 17th, pretty timely. That's pretty up to date. The numbers I just gave the member, and happy to continue to give them to the member.
Member.
Thank you, Chair. I got 8 questions. I'm just wondering how, moving forward, how I can get my constituency office direction on how they can get that updated number. It doesn't have to be daily, but, you know, just kind of once a month. How can we get that information?
Minister.
Happy to provide it.
I'm thrilled to hear that. Thank you, Chair. Second is Nanaimo Regional General Hospital. Obviously, we've seen some dramatic numbers of patients being served with only a limited number of beds. The number that I see here is March 20th was sort of the peak, 432 beds. I think there was actually a higher day than that. My understanding is that Island Health is currently looking at spending $45 million on reallocating space in the hospital to try to figure out how to get more people into the hospital space. Question through the chair to the minister is, how many beds will that provide? And local government who sit at the hospital board, my private conversations with them, they're growing impatient. They were thrilled to see the minister just recently, as was I. The cancer announcement was a much needed one and very appreciated. What will that $45 million mean for the hospital? And what will happen if, will that move forward if the hospital board decides not to fund their 40% of that investment?
Minister.
Honourable Speaker, the staff do an incredible job at Nanaimo Regional General Hospital. That's why we've made commitments and delivered on those commitments to that hospital. New ICU in place, new HAU opening, I think, shortly. New cancer center, that was a multi-decade requirement and demand, and reflects the highest cause of death in the community and an absolute need for service. We're also looking at repurposing vacated space. We are looking at that. With respect to the regional hospital, which you would want to do anyway, because such projects are on a very different timeline than major capital projects. So for the staff working there, for the people in the community, making retrofits to make space that is not being used now to do rehab space that allows other space to be opened up for other patients. Makes a lot of sense. I wouldn't, I'd be very surprised if the regional hospital district, which isn't expected on the cancer center, because most of it, I mean, we're talking about parking and other issues, but most of that investment is not for direct investment in the hospital, and is being provided fully by the taxpayers of BC. I would expect that the regional hospital district would be extremely supportive of that, as they were to the long-term care we brought, as they were to the cancer center, especially the part they don't have to pay for, as they were to the ICU, as they were for the HAU, right? This is a great hospital. I'm very committed to continuing to make improvements in the hospital. And these projects are at a very different time and space when you're doing. We just early in my time as Minister of Health, we announced the hospital in Terrace 2018, the concept plan 2019, the business plan. We're going to be opening it, final construction will end in September 2024. So that takes time. In the meantime, we have a lot of patients in that hospital, and so we've got to make the best possible use of the space. And I know the regional hospital district will be supportive of those efforts.
Member.
Thank you, Chair. The investments highlighted by the Minister are, of course, in Island Health's 10-year capital plan. So those ones were approved. I think the surprise that I'm hearing from some of the members of the hospital board was that a large portion of the cancer center they're paying for. They've got a pharmacy right now, cancer pharmacy, that is non-compliant. And a very small portion, I agree with the Minister, $200 million cancer. But you look through that list, and the hospital board have raised the concern that there's significant capital projects that they are funding that aren't on their list, and they're being asked to fund their 40% of the $45 million rearrangement. We know the pool downstairs is going to be transferred from storage to patient rooms. That's great to hear. But the question was, $45 million, how many beds can the region expect through that investment? And again, through the chair to the minister, if the hospital board doesn't come forward with their 40% on this capital project, $45 million, that's not in the 10-year capital plan, will the province still move forward with this project?
Minister.
Well, Honourable Speaker, I expect they will. I mean, the member will appreciate that, that making improvements to Nanaimo Regional General Hospital is an important thing and an urgent thing. And so we need to do smaller capital projects and bigger capital projects. And when Island Health, which after all runs the hospital, makes determination as to priorities and possibilities, then well, generally speaking, the regional hospital district will be supportive of that, as they were in the case of long-term care, but it's always a debate. The reason I'm so proud of the long-term care project is I can't think of a project more important to the people of Nanaimo, the people of the members' constituency as well, than that project. It's the most important. I've talked to the member personally about it, so he knows. He knows how I feel about that. And he knows that adding those 300 long-term care beds, what's that? And 6, right? Those 300 long-term care beds will make such a big difference, including to the hospital. And one of the challenges we have in our system is sometimes people like proposals like cancer centers more than they like proposals like long-term care, when what they need first is long-term care. I'm so proud of the work we're doing in Nanaimo, and I'm proud of the regional hospital district and everyone who advocates in the region. And you see, again and again, we're meeting commitments. And so I would be astonished if we didn't have the support of the regional hospital district for something that will make life better for the people of Nanaimo in the area. And I expect we will. And that's the work we have to do. Of course, we have to connect with them, and that work when we have projects coming forward. We have to do that work. We have to do that on the work we're doing now, and we're going to continue to do that work. But when there's an opportunity to improve the situation in the hospital for relatively less cost and sooner, then I would expect that we would have, I know that we'll have support for my colleagues from Nanaimo. I'm sure my colleague from Parksville, Qualicum will be supportive of that. All the people who are served by Nanaimo Regional General Hospital, all of our colleagues in the legislature will be extremely supportive of any proposal that makes things better at NRGH.
Member.
Thank you, Chair. And if any of the members of the hospital board are watching this, I too would encourage them to support that 40%. But these are the questions that I'm being asked. How many beds? What happens if they don't fund it? And I respect that these investments being made in our community are making a notable difference, but I've also noted that I haven't got a direct answer on both, but I'll move along. The next is the catheterization lab and the challenges there. There's a 2006 report that identifies that there is, I believe, a 3% increase in mortality because we don't have heart catheterization facilities there. I'm hearing regularly from people who have been impacted by the lack of heart catheterization facilities. My mother-in-law was turned away from the hospital. Turns out she was having MI. Had to get airlifted immediately afterwards because there was no way that they could do that test. We have a patient who recently died, cerebral hemorrhage, or I'm not sure what it was, but people get clot busters there, and they wait and they wait and they wait, and sometimes it doesn't go the right way. Obviously, this has been a request of Island Health and the hospital board. I appreciated at the recent announcement, the minister said that 5 years was too long, and so I will just use this opportunity to ask on the record, when is the appropriate time for the city of Nanaimo to be and the region to get heart catheterization facilities as they are duly needed?
Minister.
Well, the issue in Nanaimo that I was asked about was about the tower, right? Wasn't about the catheterization lab, but fair enough. I don't mind aligning these things, but that's what I was asked when they said, are we going to wait 5 years for this? These are important projects. We have the largest capital plan the province has ever seen. $17 million in long-term care in the last 10 years of the previous government. We're doing more than $3 billion in these 10 years. So that's a lot more. And we had a capital deficit in healthcare that we know. Fort St. James, temporary modular hospital, 1972, should have been done by 1982. We're finally opening the new one soon. And there are issues in Nanaimo as well around the tower. On cardiac catheterization, we have 5 centers in BC, right? And people often have to travel far for that care. We're adding a 6th now. And our teams, our cardiac teams, look at these issues all the time. Certainly would be an issue as you're assessing the capital needs of a new tower at Nanaimo Regional General Hospital. That would be an issue that you would look at. We got to improve cardiac care, though, that we are providing there. And one of the challenges in recruitment in Nanaimo is recruitment of our cardiologists and our team. And it's always been an issue, right? Which is, how do you hold people in Nanaimo when there are bigger teams in Victoria? This is a Vancouver Island issue. And I met specifically with doctors about this very question at Nanaimo Regional General Hospital in one of my previous visits there. And so I think what my priority is for cardiac care now is filling positions and supporting cardiac care for existing services in Nanaimo Regional General Hospital, making sure that those are adequate. And obviously, all of these things are part of planning processes, the future vision of the hospital. I strongly believe in that vision. That's why I answered that question that way. And what I do, though, is always depend on our healthcare teams to provide advice on what we should do at what hospital. Sometimes I get criticized for their advice, but I always follow it because there has to be a discipline to providing support for capital projects that are in the billions of dollars, including, in that range. I'm not saying billions in terms of it's more than 2 billion, I mean more than 1 billion, but in the billions of dollars is what I mean. You have to depend on your healthcare staff to provide the right advice as to what are the services you want to address. And a lot of it in Nanaimo is what I would call general medical beds, is what the facility needs, right? Not just, there's always talk about specialist care. This is a hospital that is significantly over capacity. And so those are the issues we're raising. It's why we're going to do things in the short run, why we're going to do things in the long run, why we've added service after service after service. But I would, getting back to long-term care, say sometimes the answer of what we need in the hospital isn't just in the hospital. We need better primary care. We talked about that, and better long-term care.
Member.
Thank you, Chair. And I hear that, and it's about listening to the health professionals. And what I hear from the health professionals, not just the cardiologist, I think we have 2 right now, because it fluctuates, sometimes 1, sometimes 2, is that they've identified that as a need, and they're advocating to me that that's a primary need for the community. As we talk about the performance and listening to people, Island Health has performance benchmarks. They've got 19, only 18 of them they have data for. Unfortunately, they're failing many of these benchmarks significantly. Of the benchmarks, more than 80% they're failing, and most of them, the performance is, this is their language, is the performance is significantly outside the acceptable range, and they need to take action. Question through the Chair to the Minister is, what is the Minister doing to ensure that Island Health is able to adhere to the performance benchmarks that they themselves set?
Minister.
Well, I would say, first of all, it obviously depends on what you look at in terms of surgeries. It's breathtaking, the progress that our surgeons on Vancouver Island have made, and that's been led by Island Health. On diagnostics, it's breathtaking, the number of more MRIs and CT scans we make. What's also true in Vancouver Island is an increase in an aging population and an increase in the overall population. I talked about this in previous discussions in this debate. 187,000 more people on MSP in 2022-23, disproportionately on Vancouver Island. Another 187,000 more in 23-24. Those are the largest single-year increase in population the province ever seen by a mile. That's 375,000 in 2 years. And so against that, we've significantly increased surgical and diagnostic capacity on Vancouver Island. We're building long-term care homes that have been neglected for a long time, including in the western communities, including in Campbell River, including notably in Lanceville and in Nanaimo. And I do remember looking at the site with the member not so long ago, right? And so to meet those targets requires significant investment in infrastructure. It's why we're making that investment, why we're building a new hospital in Cowichan. And the COVID-19 pandemic, of course, profoundly affected Island Health as it did everywhere else. And Island Health did everything they normally do plus COVID-19, you know, a small worldwide pandemic. So I think we've been significantly adding healthcare workers. We're adding new facilities, obviously, until they come into place. They do provide hope, though. You know, when we announced the ICU in Nanaimo, it didn't make things instantly better for people working in the ICU in Nanaimo, but they knew a new one was coming. And similarly on cancer care, all those people who travel the whole length of Vancouver Island to get care, to have a Nanaimo Cancer Center, that makes a difference. And so we are absolutely committed to improving standards on Vancouver Island and healthcare. And I think the actions that we've taken demonstrate that, and we're going to continue to take those actions.
Member.
Thank you, Chair. I recognize my time is up. I'm hoping I can ask 3 questions quickly and have the Ministry respond in writing. If that's, I got a thumbs up from the Minister, so Hansard can record that. I'm just going to read the benchmark for MRIs. I know the Minister mentioned MRIs. Their benchmark is to ensure that that people have stat MRIs within 1 day, as soon as possible within 7 days, semi-urgent within 30, and routine within 60 days. Their target is more than 85% of the time. They're only hitting that 25% of the time. Had those investments that the Minister said not been made, we'd be in a much worse spot. But these are the kinds of benchmarks that I was talking about. The questions that I'll rattle off here real quick. First is a repeat from before for the Minister. If the Minister could provide me in writing how my staff can request where we're at with the Health Connect registry counts for both ministries, or both communities, Oceanside and Qualicum. The second question is on long-term care. Looking for the number of long-term care subsidized beds that have been funded between 2017 and today, recognizing that the Minister often says that the number of people over 75 will double over the next 10 years. In our community, that's not going to happen because the number of people over 75 is already significantly high. Those 306 beds will make a difference, but looking for an update as far as how many beds, subsidized beds, have been funded between 2017 and today, and how many that this fiscal year can expect. The next is how many doctors are we anticipating in the next 10 years to see retire? How many are we anticipating to train, and how many are we anticipating to need? And then the last question is for a couple specific constituents, long-serving nurses. They've been in the system for more than 30 years. They were very enthusiastic with the last collective agreement with the top-ups for long service. The challenge is that if you work for different health authorities, there's significant barriers to getting your employment records and getting the recognition of those hours so that they can get those wages. That's all I have. I want to thank the Health Minister for not just answering my questions, but I've watched several days of answers. He is clearly knows his file and is doing the best as possible. And I thank the Ministry staff as well. And with that, I'm done. Thank you.
Thank you, Member. Well, hearing no further questions, I believe I will now call vote 32. All those in favor? Aye. Opposed? Carried. Minister.
Thank you, Honourable Chair. I move that the committee rise, report resolution and completion, and ask leave to sit again.
Members heard the question. All those in favor? Aye. Opposed? Carried. Thank you, members. Thank you, Minister. This committee is adjourned.
Committee Chair.
Thank you, Honourable Speaker. Committee of Supply for the Ministry of Health reports completion and seeks leave to sit again.
When shall the committee sit again, Government House Leader?
Next setting.
So ordered. Committee Chair.
Honourable Speaker, Committee of Supply Section C reports resolution and completion of the estimates of the Ministry of Education and Childcare and asks leave to sit again.
When shall the committee sit again?
Next setting.
So ordered. Committee Chair.
Mr. Speaker, Section A reports progress on Bill number 15 and asks leave to sit again.
When shall the committee sit again?
Next setting.
So ordered. Government House Leader.
I move the House now adjourn.
Member, you heard the question. All those in favor indicate aye. Opposed? Motion carried. This House stand adjourned until 1:30 p.m. tomorrow.